Namaste. For us today is a very important day. 40 years since Apollo has started on a mission to make world-class healthcare available for all our people in this part of the world. The goal was to make top-notch medical services accessible geographically and also affordable by lowering a cost to almost a tenth of when compared to the Western nations. This success earned us the trust of more than 100 million patients from across the world who came to Apollo from 160 countries, and it also helped us in positioning India as a global healthcare destination for best-in-class healthcare. However, we have never rested on our laurels as pioneers. Apollo has always been at the forefront to introduce the global best in clinical protocols, medical technologies, which is very important, and the state-of-the-art technologies into India. We at Apollo are committed to continuously harness cutting-edge technology in medical advancement to do everything possible to raise the bar in clinical excellence and enhance the quality of life for every patient who trusts us. Today is a momentous day marking a new beginning. The launch of Zap-X Gyroscopic Radiosurgery, the first center for this part of the world. This initiative technology will lead a monumental leap forward in our capabilities to treat various neurological conditions with unparalleled precision and safety. Zap-X is a revolutionary radiosurgery and is rapidly becoming the standard of care for most neurological and surgical conditions across the Western world. A few hospitals in the Western world have already started using it. Today, it's going to be available for people of this part of the world. Be it intracranial tumors, brain metastasis, or cerebral AVMs, trigeminal neurology, and even several movement disorders, which is very important for all the neurologists. Zap-X demonstrates its clinical efficacy and unmatched success. I am happy that Zap-X is invented by genius Professor John Adler from Stanford, who previously invented CyberKnife, which Apollo acquired about 15 years ago, and the new CyberKnife also we have bought now. And today, his later advancement on CyberKnife is Zap-X, which represents a significant advancement beyond other technologies that are available now. The upcoming scientific congress for the launch of Zap-X will be attended by illustrious Professor John Adair Prohl from the USA and Professor Max Rouge from Germany, who have already treated these patients and are very happy with the results that they have obtained from their patients. And I invite each of you to harness the state-of-the-art medical equipment to deliver the best possible care for each of your patients and make this world a healthier and happier one. I think this technology will make India lead the path in healthcare for the world, and together we'll do it. Because for us, every life is precious.
Zap-X is pain-free, non-invasive, safe, and requires no anesthesia. That's not all. Zap-X does not need an overnight hospital stay or incisions. Zap-X treatment entails 30-minute sessions. From hours of surgery, we have now progressed to 30-minute sessions, transforming delivery of care and improving quality of life like never before. Reduced radiation to healthy tissues ensures a quicker recovery, allowing patients to heal faster. From consultation to post-treatment, we have reimagined care to deliver an unmatched experience every step of the way.
We at Indraprasth Apollo Hospital are revolutionizing neuroradiosurgery with Zap-X. Trust Apollo and Zap for innovation, precision, and excellence in surgical outcomes.
As a neurosurgeon, precision is paramount in treating brain tumors and other neurological conditions. That's why I trust Zap-X, the cutting-edge solution for osteotactic radiosurgery.
Namaste. For us today is a very important day. 40 years since Apollo has started on a mission to make world-class healthcare available for all our people.
It was yet another busy day for Harish and Hema. Work was intense and stressful. Balancing with home commitments made it hard to prioritize their health. Sounds familiar? Let's see what happens to Harish and Hema when Apollo Pro Health came into their life. A health program that could predict, prevent and help them overcome lifestyle diseases. Pro Health began with a set of questions about their medical and family history as well as lifestyle choices. This generated personalized tests specific to Harish and Hema. Then they went to an Apollo center for their diagnostic tests. These tests can ensure early detection of most common health conditions that often go undetected for too long. Addressing them early allows for limited medications, minimal doctor visits, and in some cases even reversal. Using an artificial intelligence tool, the doctor predicted their health risks, discussed their test results, and helped create personalized goals for Harish and Hema, and thus began their path to wellness that was all about eating healthy, regular medication, and staying fit. In a few days, they got a call from their health mentor, who shared diet and exercise tips and reminded them to update their progress periodically on the Apollo app. There was no escaping the exercise routine. The app constantly reminded them to complete their daily physical activity. Their prescribed medication was delivered right to their doorstep, and doctors were always available for check-ins on their progress. Pro Health is designed to make you healthier tomorrow than you are today, with the support of Apollo doctors. Get on to Apollo Pro Health now. Call 1-860-500-0707 and take full control of your health.
Namaste. For us today is a very important day. 40 years since Apollo has started on a mission to make world-class healthcare available for all our people in this part of the world. The goal was to make top-notch medical services accessible geographically and also affordable by lowering a cost to almost a tenth of when compared to the Western nations. This success earned us the trust of more than 100 million patients from across the world who came to Apollo from 160 countries, and it also helped us in positioning India as a global healthcare destination for best-in-class healthcare. However, we have never rested on our laurels as pioneers. Apollo has always been at the forefront to introduce the global best in clinical protocols, medical technologies, which is very important, and the state-of-the-art technologies into India. We at Apollo are committed to continuously harness cutting-edge technology in medical advancement to do everything possible to raise the bar in clinical excellence and enhance the quality of life for every patient who trusts us. Today is a momentous day marking a new beginning, the launch of Zap-X, Gyroscopic Radiosurgery, the first center for this part of the world. This initiative technology will lead a monumental leap forward in our capabilities to treat various neurological conditions with unparalleled precision and safety. Zap-X is a revolutionary radiosurgery and is rapidly becoming the standard of care for most neurological and surgical conditions across the Western world. A few hospitals in the Western world have already started using it. Today, it's going to be available for people of this part of the world. Be it intracranial tumors, brain metastasis, or cerebral AVMs, trigeminal neuralgia, and even several movement disorders, which is very important for all the neurologists. Zap-X demonstrates its clinical efficacy and unmatched success. I am happy that Zap-X is invented by genius Professor John Adler from Stanford, who previously invented CyberKnife, which Apollo acquired about 15 years ago, and the new CyberKnife also we have bought now. And today, his latest advancement on CyberKnife is Zap-X, which represents a significant advancement beyond other technologies that are available now. The upcoming scientific congress for the launch of Zap-X will be attended by illustrious Professor John Adair Prohl from the USA and Professor Maxman Rouge from Germany, who have already treated these patients and are very happy with the results that they have obtained from their patients. And I invite each of you to harness the state-of-the-art medical equipment to deliver the best possible care for each of your patients and make this world a healthier and happier one. I think this technology will make India lead the path in healthcare for the world, and together we'll do it. Because for us, every life is precious.
Zap-X is pain-free, non-invasive, safe, and requires no anesthesia. That's not all. Zap-X does not need an overnight hospital stay or incisions. Zap-X treatment entails 30-minute sessions. From hours of surgery, we have now progressed to 30-minute sessions, transforming delivery of care and improving quality of life like never before. Reduced radiation to healthy tissues ensures a quicker recovery, allowing patients to heal faster. From consultation to post-treatment, we have reimagined care to deliver an unmatched experience every step of the way.
We at Indraprasth Apollo Hospital are revolutionizing neuroradiosurgery with Zap-X. Trust Apollo and Zap for innovation, precision, and excellence in surgical outcomes.
As a neurosurgeon, precision is paramount in treating brain tumors and other neurological conditions. That's why I trust Zap-X, the cutting-edge solution for stereotactic radiosurgery.
Namaste. For us today is a very important day.
It was yet another busy day for Harish and Hema. Work was intense and stressful. Balancing with home commitments made it hard to prioritize their health. Sounds familiar? Let's see what happens to Harish and Hema when Apollo Pro Health came into their life. A health program that could predict, prevent and help them overcome lifestyle diseases. Pro Health began with a set of questions about their medical and family history as well as lifestyle choices. This generated personalized tests specific to Harish and Hema. Then they went to an Apollo center for their diagnostic tests. These tests can ensure early detection of most common health conditions that often go undetected for too long. Addressing them early allows for limited medications, minimal doctor visits and in some cases even reversal. Using an artificial intelligence tool, the doctor predicted their health risks, discussed their test results and helped create personalized goals for Harish and Hema, and thus began their path to wellness that was all about eating healthy, regular medication and staying fit. In a few days, they got a call from their health mentor, who shared diet and exercise tips and reminded them to update their progress periodically on the Apollo app. There was no escaping the exercise routine. The app constantly reminded them to complete their daily physical activity. Their prescribed medication was delivered right to their doorstep, and doctors were always available for check-ins on their progress. Pro Health is designed to make you healthier tomorrow than you are today, with the support of Apollo doctors. Get on to Apollo Pro Health now. Call 1-860-500-0707 and take full control of your health.
Good afternoon, ladies and gentlemen. We'll start the scientific session now. Distinguished guests, esteemed participants, welcome to the scientific session on Zap-X, where innovation meets excellence in the field of neurosciences. I'm Dr. Fawzia Khan, and I'm your host for this exciting scientific session today. This is dedicated to exploring the advancements in medical technology, specifically the groundbreaking Zap-X. It is truly an honor to stand before you all as we embark on a journey into the future of healthcare. Today, we have the privilege of delving into the intricacies of a revolutionary technology that is shaping the future of medical treatment, the Zap-X. Today, we gather not just as spectators, but as active participants around a technological marvel. In a world where innovation is the driving force, Zap-X stands out as a beacon of progress, pushing the boundaries of what we thought was impossible in the realm of medical science. This state-of-the-art system is designed to treat brain tumors using groundbreaking self-shielded gyroscopic linear accelerator design that makes it possible to target the tumors from hundreds of unique angles. The session promises to be insightful, educational, and perhaps even a glimpse into the future of healthcare. On that note, I request Dr. Anupam Sibbal, our Group Medical Director, Apollo Hospitals, to give the welcome address.
Good afternoon, Namaste. Thank you very much, Fawzia. It's indeed a privilege on behalf of the Apollo Hospitals Group to welcome you all to this scientific session. Today is a very important day for us because it marks a significant milestone in our commitment to delivering clinical excellence and that too in the field of neurosciences. We actually have a very rich tradition in neurosciences and for many of us who don't know Apollo that well, while Apollo was established in 1983, the first neurosciences center was established at Apollo Chennai way back in 1990. And there have been many firsts that neurosciences has seen at Apollo
including the first JCI accredited stroke program in the world, which was in 2006 at Apollo Hyderabad. We were also the first to bring in John's first invention, cyberknife, and since then several new technologies have been brought in. We've got a stroke network, we have an AI-driven stroke program, we've been following the FAST protocol now across our system for a while. All the subdivisions of neurosurgery are practiced from base of the skull to vascular, to pediatrics, to micro, and of course a foray has been made with deep brain stimulation and epilepsy surgery. So we're really delighted that we are making a definite move in the direction of where the world is headed with the acquisition of Zap-X. Over the years, we've actually performed 210,000 neurosurgeries across 37 units of Apollo. And today we are really delighted, in addition to our foreign faculty and faculty from non-Apollo institutions, but senior consultants from 10 Apollo hospitals. And we have colleagues joining in from the other 27 units who could not come here in person. While we've been able to deliver some high-end care in neurosciences, we're also very proud of the fact that we have established a foothold in academics and research. We actually have 12% of India's D&B trainees across 54 specialties in 22 centers. And that 12% will become 15% because currently we have more than 1,200 trainees. And in neurosciences, we have 16 D&B trainees in neurology and 14 in neurosurgery. So we believe academics and research go hand in hand when you want to deliver the best quality clinical care. Today we are delighted to welcome our very dear friend John Adler, who has really been a great friend of Dr. Reddy and has been our partner for many, many years. So thank you so much, John, for bringing the first Zap-X to India. We are delighted to welcome John Adair Pral. Thank you so much, John, for taking the time to come in from Colorado, and to Professor Maximilian Ruge for his time and flying in from Germany. Deeply appreciate that. And of course, the amazing faculty that we have from across the country, the Apollo ecosystem and the non-Apollo ecosystem, and to all of you who've joined online. I'm pretty certain that this is going to be an exciting session where we're going to all get enriched and leave a lot wiser than we were this morning. Thank you very much.
Thank you, Dr. Sibyl. Before we dive into the intricacies of Zap-X, let's take a moment to recognize the brilliant minds who are gathered here today. We have an esteemed panel of speakers, panelists, and experts who will be sharing their invaluable insights on SRS and Zap-X. Your dedication to advancing the frontiers of medical science is truly commendable, and we are grateful to your presence. Our first speaker for today is Professor John Adair Pral. Professor Pral is the Director of Neurotrauma at Littleton Adventist Hospital in Littleton, Colorado, and is a co-founding partner of Neurosurgery One, the largest neurosurgical practice in the Rocky Mountain region. Professor Pral has been practicing neurosurgery and spine surgery for more than 30 years. He is experienced in all types of cranial and spinal surgery, is nationally renowned for his expertise in vascular compression syndromes, including trigeminal neuralgia. His radiosurgical experience is extensive, with experience on Gamma Knife, CyberKnife, TrueBeam, and now the Zap-X platform. Professor Pral will be speaking on experience on Zap-X radiosurgery. The eminent chairpersons for this session are Dr. Satish S., a highly skilled neurosurgeon with more than 30 years of experience from Apollo Hospitals, Bangalore, Bannerghatta, and Dr. Rahul Lat, another accomplished neurosurgeon from Apollo Hospitals, Jubilee Hills, Hyderabad, with more than 20 years of experience. I now hand the session to the eminent chairpersons to carry it forward. Professor Rahul and Professor Dr. Satish, please come on the stage.
good afternoon to all the delegates and visiting faculty. We'll start the session now, and may I welcome Professor to give his talk. Thank you.
Yeah.
I'll stand here.
To advance. Just to advance, right? Yeah, better. Okay, thank you. Is there a pointer? No, that's good. No, look. Okay, sure. Okay. Well, thank you all very much. Good afternoon. I very much appreciate the invitation from Dr. Reddy and the Apollo team here. I've been quite struck by the energy and enthusiasm of all of the staff here about the Zap-X in particular, but about your neuroscience program in general. So I very much appreciate being part of the program. So what I wanted to talk about today, a couple of things here. I wanted to give kind of an overview of the Zap-X technology, kind of summarize the workflow, which is probably very similar to other platforms that you all are familiar with, capabilities, and then a summary. Sorry, this is actually the wrong talk. Let's see. Yeah, we have. There you see, key point. This is not. There's another one in here. Can I just connect to my own computer? I don't think it's even. Well, I thought the Zap-X intro.
This one.
This one.
This one.
Double click that. Is that the same thing?
This is one.
Yeah, see, that's the same thing. Can you connect me?
Can I connect your
my
laptop?
Apple. This isn't my talk at all.
Yeah, you get your laptop right now. I will be connected.
Can you do it? I have it, but it's an Apple.
It's okay. We have.
You should change your order of speakers. All right, sorry about that. Technical glitch. Let's see here. There we go. So here's what I'd like to talk about. A little bit about my own practice in Colorado, in the United States, and then a short introduction to Zap Surgical, although you'll be hearing more from Dr. Adler about that. A quick technical overview of the Zap platform that you all are starting to use now. Some about the clinical workflow and some planning studies, some examples of planning studies, and capabilities, and then our own experience to date, which is not extensive as of yet. We're just getting started with our program. So my practice is a community practice, non-academic practice. And as you heard, I've been in the same place for about 30 years in Colorado, which is in the Rocky Mountain area in the United States, aligned with a major health system. For a long time, there were just 2 or 3 neurosurgeons in our group, and it's really just been in the last several years that we've grown quite a bit, now to 10 and expanding another 2 this summer, and neurosurgeons, and then pain management specialists, as well as mid-level providers, which I'm not sure if there's an equivalent here, but nurse practitioners and physician assistants, which is a major part of our team. We do about 200 surgical cases a month among the different surgeons, 20 or so % of it cranial. A large part of it is spine, which we won't really be talking about today, but around 100 or 120 radiosurgical cases between myself and primarily 2 other partners in the group who do the majority of these. And as you heard, my experience has been primarily with Gamma Knife, Varian, TrueBeam, and more recently the Zap-X platform. So just to put it in perspective, Metro Denver population is only 3 million, so a fraction of the Metro Delhi area and beyond. Our whole state, there are only 5 million people in the state. Given that, though, there are 2 different Gamma Knife centers in Denver, 2 CyberKnife centers, and many, many linear accelerator centers. There's no regulatory requirement for certificate of need, and so it ends up being kind of a free market activity in terms of opening different centers. So there's quite a bit of competition. There's a large corporate practice that's throughout the United States, but very strong in our area, U.S. Oncology. And then there's a strong academic program as well, the University of Colorado, where I trained many years ago now. So just to paint the picture that there's quite a bit of competition for oncology and for these types of patients. So as a result, a lot of our patient referrals are self-referrals. Patients with, and primarily benign disease, meningiomas and acoustic neuromas and trigeminal neuralgia, which is actually something that you heard I have a great interest in and have been doing quite a bit of for a long time. Marketing and social media are very important in our message delivery as well. So this is just a picture of our unit. Looks a lot like your Zap-X. A little bit different room and environment, but as you can see, we'll talk about later, those are windows right next to the machine to be able to look outside as they're starting and finishing up their treatment. On the right, my partner, Dr. Bagosi, my radiation oncologist, and this is our first patient, acoustic neuroma patient. So just a little bit about Zap Surgical. I know you'll hear more later, but company founded by Dr. Adler, who's here with us in the audience, who also gave us the CyberKnife a number of years ago, has had a varied career and with a number of different companies and institutions headquartered in Silicon Valley in California. And we call it the Zap familiarly, but it's officially the Zap-X Gyroscopic Radiosurgical Platform. And here I just wanted to throw in, we were in Littleton, Colorado. This is where we are on the map outside of Denver. I call it Denver, but it's a suburb of Denver. Something like the 7th or 8th or 9th center to go online, I believe. And as you can see, there are centers popping up all over the world now. online centers in blue, and committed plans for centers in yellow, primarily in North America, Western Europe, and in Asia, and now here we are here in Delhi. So a little bit about the Zap-X and how it works. You may have seen snippets of this in the last day or two. I thought it would be worthwhile to show this. It's just a short video that kind of gives different aspects of the machine. Let me see if I can make this work for us. There's some volume that goes with it that you probably don't need. It's just musical background. I'll go over some of these different aspects of the platform in a few minutes. All right. I'm sorry, there's some very nice background music there that wouldn't come through for the computer change. Couple of things that I think are important to talk about with the platform and the way it's different from other platforms. The degree of different non-coplanar beam angles is immense with this platform, significantly more than with Gamma Knife and Cyber Knife. And that comes from, with Gamma Knife, improved inferior beam positions relative to Cyber Knife from underneath the head or the table, and in multiple ways as compared to traditional LINAC platforms. And the objective there is to reduce the dose gradient, put the dose on the target and reduce the dose to adjacent brain and critical structures. There's very low beam collimation leakage as well, 0.002% of the primary beam with the Zap, which is dramatically smaller than with multi-purpose LINAC platforms. Again, reducing non-therapeutic dose outside the target and maximizing it on the target. The lower energy LINAC beam is designed that way intentionally, similar to the energy level of a gamma knife, and considerably less than with most LINAC platforms, in order specifically to address that beam energy dissipation of energy on tissue around the target. Again, reducing the dose gradient. And the penumbra, which has been entered into the delivery of the beam, is exceedingly steep, as I'll show you, favorable to the gamma knife, let alone LINAC platforms. And that has to do with the 45 centimeter source, which is considerably, the source axis distance, which is considerably shorter than in LINAC platforms. This just serves to sharpen the edge of the beam and decrease dose to adjacent tissue. The system utilizes a mask, a molded mask, as an immobilizer, and it doesn't require a frame at all. And patients really appreciate this in my experience. Now, this is true with LINAC-based platforms as well, so it really differentiates it from some of the gamma knife platform, even though it too can be used frameless as well these days. There's also, within fractions, at user-defined frequencies, the motion management where KV beams can be utilized, not unlike the CyberKnife technology, to compare back to the baseline to be sure that there's been no movement. Here's just an example of the beam profiles, with the green being the Zap, the blue is the gamma knife, and red is CyberKnife, and LINAC considerably less sharp, not even shown here on the graphs. But as you can see, the steepness of the beam is considerably better than the other platforms in X and Y, and similar in Z. And this makes a big difference, especially with a big dose on for instance, a trigeminal case. A big dose on a target that's very close to critical structure adjacent to it, just by changing even from the 5 to a 4 millimeter collimator, you can see the difference in the amount of brainstem subjected to higher amounts of radiation. Another advantage with a dedicated radiosurgical platform for cranial use is the limitation of non-therapeutic dose to the body as well. That's why the beam delivery has been crafted to avoid approach angles from the top of the head that would otherwise be going through the body. So this decreases the risk of potential secondary malignancies, especially in younger patients who often have benign disease, trigeminal neuralgia, and other benign tumors. As we saw in the video, this platform with its self-shielding allows for a vault-free environment, which is really a game changer. Apollo's taken advantage of that here, putting it in a windowed suite, although the windows can can be clouded, but essentially right next to a lobby area. It was a beautiful way to put the machine and make it available for people to see as they're wandering by. But more importantly, in my experience, it really makes the patient more comfortable. And you know, I think in talking to John in the last couple of years, I think this was very intentional. The idea of demystifying the radiation treatment experience for patients, very intimidating, as many of you know, I think. And I think this goes a long way, having staff or family in the same room as the treatment, having windows to the outside or to exterior areas right next to the machine. Another important part of this, as compared to at least cobalt based systems, is that it's cobalt free. So cost, need for maintenance, need for source reloading all goes away. The dose rate will stay the same essentially forever, very much unlike a Gamma knife, which for those of you who've used Gamma knives, in your experience, the difference in time of treatment between the reloading of sources and the soon to reload again several years later, 4 or 5 years, the difference in time of treatment is dramatic, double essentially. Trigeminal treatments go from 28 or 30 minutes to over an hour in my experience. Again here, cost and security as well. I don't know what the rules are like here in India, but in the United States there's special systems where guards come running if the door to the Gamma knife vault has stayed open beyond a certain number of minutes, 2 minutes, 3 minutes. So we're always remembering to shut the door whether we're inside the vault or outside. That all goes away. Patient safety, obviously foremost in thinking and engineering of the platform. Instantaneous position verification, the MV detector, and I'll show you in a minute with some diagrams, but there's an exit dose panel that's looking and comparing exit dose to expected exit dose with every single beam, essentially, that's delivered. And so in real time, you're seeing if, in fact, what you think you radiated, you really did radiate. And they're automatic as well as user-defined thresholds for stops to recalculate positioning throughout the fractions. So here's just a cut drawing I thought was kind of interesting. We've all seen the outside of the machine, which essentially is a globe with a part sticking out. But this is the cut drawing, and it gives you an idea with a patient inside. First of all, the axes of rotation, engineered with 2 separate axes to allow that large area of beam delivery around the head, but trying to avoid beams that are going through the body outside the head. The shielding is such a revolutionary part of this machine, the self-shielding. The globe itself, then the mesh that you see on the outside, is the shielding of the main portion, the main chamber, and then the shell that comes over the top of the legs and the gate that comes up at the foot complete the shielding of the machine. And just some of the components here, the X-ray, the KV tube that I talked about, and the imaging detector going through the patient just to ensure positioning stays exactly the same throughout the course of treatment as it was at the beginning. As you saw in the video, a huge range of collimation from 4 to 25 millimeters built into the system. And I think this is really an important piece of this too. As Dr. Adler said yesterday, they're there is the occasional patient who feels a little claustrophobic in the machine, and I haven't had anyone that we couldn't give a very small amount of sedation to by mouth to be able to do their treatment. But inside where the patient is, the chamber is quite large, and if you compare it to maybe not a CT bore, but an MRI bore, for sure, it's quite a bit larger than that. And as the picture suggests, almost, probably can't quite, I couldn't stand up in there. I don't know if others could, but it's a large amount of room. So the occasional patient is a little uncomfortable being in an enclosed space, but not like an MRI where the tube is right against one's face or nose. So what are the different things that we treat with this machine? The list is long. This is a partial list within the head and even down into the cervical spine. We're playing with the idea of some soft tissue neck tumors, but so far have just stuck to cranial targets, intracranial targets, but they include both benign and malignant disease. Metastases, as I mentioned, we don't have much experience with because of our referral pattern. I'm sure there'll be many more of those here on the Apollo platform. And so the clinical workflow is very similar to what you may be familiar with on other platforms, at least LINAC platforms. The patient typically sees me for an appointment, and then same day or shortly thereafter sees my radiation oncologist colleague, gets set up for treatment with a mask and a CT simulation, and at some point MRI is done. It could be the same day. So occasionally people come from far away. I'm sure that will be the case here many times, and all of this can be accomplished largely in the same day, perhaps with the treatment the next morning, and then people can go home. The CT and the MRI images are fused, and then contouring is done. Dose calculation, there's inverse optimization software, or it can be done manually. Either one is available to the user. On the day of the treatment, the patient is helped onto the couch and immobilized with their mask, and then you saw this in the video. This shows up on your workstation with KV images in different planes, and simply making sure that patient positioning is satisfactorily similar to their simulation. And then they get their treatment. As we all know, they don't feel anything, and then the patient can, the KV imaging can be repeated any number of times during the fraction, and then the patient is helped off the table and out of the department, and in my experience, go out and have their lunch or go back to work, or literally there's really no recovery at all. So here are just a couple, I thought it'd be worthwhile just to give you a couple examples of treatments, types of treatments that we've done. This one may be a more common one for you here at Apollo than what we do, but multiple metastases, small metastases, 2, 3, 4, and this one is a patient with 3 Mets. The planning is trivial in this kind of treatment. A single isocenter for each metastasis with 24 gray conformally covering each Met, and a 20-minute treatment, and the patient's on their way. The whole brain mean dose less than half a gray. Trigeminal neuralgia, again, a trivial plan, a single isodose We use 90 gray. There's obviously a range that people are comfortable with in different centers. But over 250 beams, but one isocenter, and very little brainstem exposure over 12 gray. You can see there, 7/100th of a cc. 30-minute treatment that stays that way no matter how long you are running the machine. Acoustic neuroma, this is a smaller one, but again, a very short planning time, about 40 minutes to treat. Now in these cases, as you all are probably familiar, we're much more careful with larger number of isocenters to try to, as elegantly as we can, deliver enough dose to the tumor without affecting the cochlea. So here the mean dose just 2.5 to the cochlea, but with I think this was a 12 gray treatment to the acoustic. And then here just kind of a comparison between a cobalt-based system in terms of planning. This was just take the same tumor, plan out a treatment with a Zap and compare it to one that you might plan with a gamma knife. In whether you look at target coverage or brainstem exposure or mean cochlear dose, the Zap actually ends up looking favorable to an experienced gamma knife center planning regimen. And so here's my experience, just to give you an idea. Again, we're just getting started with in our center, but as Dr. Adler joked yesterday with me, I've treated more patients with a Zap than he has, actually, at this point. He invented it, but I get to use it. So anyway, it's been 26 months since we went online with our center. We had quite a bit of QA, with kind of getting comfortable with the machine, and at that point, just a handful of other centers using it. So we did our first case 7 months after we went online. We've done about 40 cases so far, which is roughly a third of the same number that I've been involved in radiosurgical cases with the TrueBeam, which is just down the hall from our Zap machine. But we're ramping up in a way that we're at about 3 or 4 or 5 Zap cases a month the last couple of months, so about 50 a year or so. And our very first trigeminal case was just the week before I came here to join you at this conference, and so that was the last indication that our radiation oncologist and physicist were getting comfortable with, and so I think that's an accomplishment. I think now we'll be able to treat most of my trigeminals, which are typically 50 or 60 a year. So we'll probably double our volume in the next 12 months or so, and about 100 a year is about where we'll probably be going forward. We've done a handful of multifraction patients too. Just a couple of notes about our install. Generally, it was as planned, and I actually haven't asked anyone how things went here, but there are always hiccups, and actually the Zap staff were more organized than our hospital staff were. To be honest, our major hiccup was having a crane to deliver the pieces through the wall into our part of the building where the machine was going to go, blocking ER entrance at we have a trauma center, and so they couldn't let that happen, and that took us a few days or a week to get a different crane, bigger crane from a different spot. But other than that, it all went very smoothly. Regulatory issues tend to be a big deal in the U.S. because people have never seen a system where the staff are in the room with the machine, so that takes some education. Just a couple of startup recommendations, and then I think this is very important. I think you have this here. Champions from neurosurgery, physics, and radiation oncology are really, really important and crucial, really. I think our startup would have been quicker and our utilization we'd be helping more people more quickly if we had those champions in all of those disciplines. I think I was the chief champion and in our center, and have had to bring along physics and radiation oncology, but I think we're all on the same page now. Taking advantage of the planning system for physicists and radiation oncologists that are used to a LINAC platform. Please consider using the inverse optimization software and take advantage of the fact that most of these plans really can be 10 or 15 minute plans as opposed to over several days. I think the bottom line is the ramp up is always going to be a little bit longer than you would like or expect, just with everyone getting more comfortable with new technology. So why does the world even need another SRS platform here? There are certainly shortcomings of cobalt-based systems, sources, replacement, vault construction, and that frame, and of multi-purpose platforms too. Margin expansion for accuracy issues, suboptimal dose gradients, and extracranial radiation, especially in younger patients. So with that, thank you for your attention. I think what people here have done and what Dr. Adler has done is really think outside the box in terms of technology and approach to this same problem. And I appreciate you all for letting me be here with you.
Thank you, Professor Prahl, for your presentation. And any questions from the audience?
Thank you.
Ravi.
Thank you, Professor Prahl, for a very illuminating talk on Zap-X. Very impressive. You didn't mention anything about pediatric indications. Does it have the same shortcomings as other photon-based radiotherapy as compared to proton in saving the hypothalamic pituitary axis, pituitary tumors, and craniopharyngiomas?
Yeah, that's a great question. I'm not sure. Is there pediatric work being done anywhere, John, right now? You can probably speak to it, and Dr. Rouge. Yeah, and Dr. Rouge as well. I don't have any experience with it myself, but it sounds like you'll be hearing more about it this afternoon.
Thank you very much. I have one question about, you mentioned that you have done something like about 1/3 of the cases are now going in for ZAP compared to the other two technologies which you already have. So going forward, or even in your protocol, how do you define a case is going to be suitable for Zap-X or TrueBeam, or is it good for CyberKnife? Are there any guidelines, or do you look at it by pathology? How do you decide the patient goes to which technology?
Right. Yeah, that's a great question. I'm fortunate in that we really, in my institution currently, we only have two platforms. We have a LINAC, traditional LINAC, TrueBeam, and the Zap. I've had access to the Gamma Knife and used it several hundred cases over time in another part of the city, and so I've stopped doing that, and partially for political reasons, health systems and things like that. But now it's fairly easy because unless there is something that my radiation oncologist feels like it's something that she would feel more comfortable on the LINAC platform, I'm always going to be using the Zap going forward. I think that the advantages of the cranial dedicated platform really make it the thing that I should be using. If we had a Gamma Knife before the Zap, if we had a Gamma Knife on campus, I would have been using that as well. But fortunately, we don't, and I got to get familiar with a Zap platform. Yeah.
one more, if I may ask one more question, Professor, one final question.
Please.
From me.
Please.
What is your experience with AV malformations and how is the planning different in those?
I don't have any with the Zap yet, so it will be interesting. With the Gamma Knife, we were starting to do stage partial treatments for bigger AVMs and doing some things that were a little less traditional. And we have an incredible neurointerventional team that we work with as well. I did just do this week a dural AV fistula, but several days ago. So we'll see. We'll have to see what the clinical outcome is there. But I think that is going to be an absolute indication, like it has been with other cranial dedicated systems, for sure.
Can I ask one question? When you are using the mask for this regarding little bit of technological things, I'm asking, like we are putting mask both for the, like we are using CyberKnife, now the Zap-X, the movement that we have, no, little bit of micro movement, and how do you, is there anything superior in Zap-X compared to CyberKnife?
Yeah, I would say that the technology is very similar, and Dr. Adler may be able to talk to this in his talk, or Dr. Rouge, but it's been my experience. I was actually quite a skeptic when I was a Gamma Knife user about the mask's ability to immobilize the patient adequately, but I really have become a believer, especially when Elekta made a machine that you could use a mask on. They themselves decided that the frame wasn't necessary, and honestly that was a part of my change in thinking. But I've been impressed that there's actually a real-time display on the Zap where you can look at sub-millimetric changes in positioning of the head. And as the fractions are going, you can set it for a certain number of certain number of seconds, and the variation is between 0.2 or 0.3 in either direction of a baseline, almost universally. So you have to believe those numbers, but it's been my experience then when you recheck your positioning with a KV. Pictures that you're exactly where you were when you started, and if the patient's coughing or moving within the mask, then you're going to see it, and you can interrupt and reposition the patient if you need to. So far, I've been very comfortable with it.
Thank you.
Thank you, Professor.
Now I invite Mr. Harshad Reddy, Director Group Oncology, to please felicitate all the speakers. Dr. Harshad. I now request Mr. Harshad Reddy to felicitate our chairpersons too. Thank you, Professor Pral. Thank you, everyone. Zap-X is a name that resonates with innovation and precision, represents a paradigm shift in medical treatment. It is just not a technology, it's a promise of improved patient care, enhanced precision, and a future where medical interventions are more effective and less invasive. On that note, I invite Dr. Gaurav Tyagi, a young and dynamic neurosurgeon from Indraprasth Apollo, Delhi, who shall be moderating this next panel discussion of ours. The panel discussion is based on a neurosurgical perspective on the next radiosurgical frontier, use of SRS in functional disorders. I request Dr. Gaurav Tyagi to please welcome the chairperson for this session, Dr. Manas Panigrahi.
Good afternoon, everyone. Thank you for this opportunity. I would like to call upon the panelists to the stage. So, chairperson for this panel discussion will be Dr. Manas Panigrahi, Dr. Dwarkanath Srinivas, and Dr. Manjul Tripathi. And this, please change the picture. Yep. So, in this session, we will be discussing about the final frontier for radiosurgery, which is going into neuromodulation. And we'll keep this discussion academic plus informal, as well as much informative for neuroscience people. And in between, any questions, any didactic communication will also be involved. So, Dr. Manas Panigrahi, Dr. Deepak Arjun Das. Dr. Manas Panigrahi is chairman and head of the department at KIMS Hospital, Hyderabad. Professor Dwarkanath Srinivas is former head of department from NIMHANS, Bangalore. Dr. Manjul Tripathi comes from PGI Chandigarh, is a masterful name now in neuroradiosurgery. And Dr. Deepak Arjun Das is an eminent neurologist from Chennai. So to begin with, we'll be talking first about trigeminal neuralgia and the role of stereotactic radiosurgery in trigeminal neuralgia. And I would like to direct my first question to Dr. Manas, and we would like to talk about who, in your opinion, should be the ideal candidate for stereotactic radiosurgery, and take the discussion forward.
Trigeminal neuralgia is one of the commonest cause of hemifacial pain. The ideal treatment is to go for microvascular decompression, but in absence of a compression in vascular compression on the trigeminal nerve, then one can think of alternative treatment like radiofrequency listening or gamma knife. And especially if the patient has morbidity like hypertension, diabetes, where he cannot undergo frequency listening. Those cases, we suggest them to go for radiosurgery, or patients who do not want to have any incision, doesn't want any injection, something. So, who prefers doesn't want to go to the theater. Those patients we suggest for radiosurgery.
Would you like to add anything to?
Thank you, Dr. Gaurav. Yeah, thank you, Dr. Gaurav, and nice to see you. And for all those not knowing, Dr. Gaurav was a faculty at NIMHANS, and it's very nice to see him. Proud of him to be here and moderating the session. So the policy we follow in NIMHANS is like this. I mean, we have done almost 7,000 to 8,000 gamma knives in the last 10 years, 10-15 years. And we operate quite a bit and also do radiofrequency ablation. So the present standard of management for trigeminal neuralgia would be surgery, especially the patient is surgically fit. The question is, when do you advise the patient for gamma knife, and why is this difference? So the best surgical results in world literature says that almost more than 95% to 98% of all patients respond to become pain-free after MVD, while the same response rates after gamma knife is around 70%. But what we have noticed is that those patients who become pain-free after gamma knife for trigeminal neuralgia continue to remain pain-free for a longer time. unlike those with RF lesioning who tend to recur within a short period of 1 to 2 years. So our policy is that if the patient is a good surgical candidate, we generally advise surgery. But if the patient happens to be a poor candidate for surgery or has comorbidities or is surgically, there is no obvious compression which is visible on the scans, these are the patients whom we advise gamma knife.
Dr. Deepak Arjundas, from a neurologist perspective, how do you see stereotactic radiosurgery going for cases of trigeminal neuralgia?
We usually give it in patients who have finished surgery and who come back with pain. We refer that group of patients. And we get patients after the surgery who complain of dry eyes and a little bit of different feeling on that part of the face that is involved. But I think that we use MBD as the first option, and patients who are on anticoagulation, unfit for surgery, fear of surgery, and do not any incision, we refer them for radiosurgery.
So now I would like to ask Dr. Manjul Tripathi, who also has a keen interest in doing MVDs as well for trigeminal neuralgia. And for your patients who you do not consider candidates for surgery, and of course they have not had good results with medical management, how do you say SRS versus other ablative procedures? What would be your preference in the order?
So it's a very custom tailored approach. First of all, the original question was, who is an ideal candidate? The ideal candidate is a person who is a typical trigeminal neuralgia, early in the course in the natural history of the disease, preferably before 2 years of the onset of the disease. I consider it as a disease which is similar to the epilepsy. If you just allow the disease to become medical refractory, allow it to linger on for a longer duration of time, that disease converts from a focal disease to a network disease. So a typical trigeminal neuralgia, irrespective of the age and irrespective of the neurovascular conflict. The neurovascular conflict has nothing to do unless it's a mega dolichoectatic blood vessel where you have a direct compression, you have a visible compression over there. So that patient becomes an ideal candidate for gamma knife radiosurgery, and the results, the pain-free interval in those patients, especially if they are in the BNI 1 to 3, are excellent. Most of these patients are now already aware of the treatment options, and once they come to you, your expectations with the treatment outcome and their treatment outcome of expectation should meet. That's another indication, because if they want an immediate pain relief, that's usually not possible with gamma knife because there is a latency period with any kind of a radiosurgery, so you need to wait for a certain duration of time, and that might extend from 3 days to 3 months. My second indication becomes when the trigeminal neuralgia is secondary to some ischial-based pathologies. Usually in those patients, I immediately give an option of surgical excision and the decompression of the tumor because that gives a better result. The third patient becomes in whom the gamma knife is being used as a secondary procedures when the patient has become a resistant craniofacial pain. And in those cases, probably sometimes I need to do with the dual targeting the trigeminal nerve and the centromedian ones. So yes, it has to be very custom tailored. Very rarely in India also we get multiple sclerosis related trigeminal neuralgia, but pain control in those patients is not that robust as you usually see with the classical trigeminal neuralgia.
Also, how do you choose between SRS versus other ablative procedures? So is going for radio frequency ablation a common practice, common in your practice?
Not in my practice.
Sir would like to say.
No. Radio frequency ablation, the incidence of hyposthesia is higher than radio. I don't send frequency unless the patient cannot afford, then because it's a cheaper option. So the side effects are less in radiosurgery versus ablation.
And it also has more recurrence as well. Yes.
RFL is a very outpatient procedure, and we have a trust that does it free of cost. So that is our option. Once we give the medicines, we set up RFL, then once they're not better, then we take it forward.
Okay. And so we would like to comment upon how much time does it take for effect to come after radiosurgery for trigeminal neuralgia?
I think Manjul it's anywhere between 1 day to 3 months, and that's the usually standard response. One thing which Dr. Manjul made as an interesting point was on secondary trigeminal neuralgia, secondary to small petrous tumors and all that. we just completed our study, and we had around 90 or 95 patients who presented tumors with trigeminal neuralgia, and we treated them with a dose for the tumor, not the trigeminal neuralgia dose. And almost 60-70% had a good response of pain. So it is not necessary that when you are treating secondary trigeminal neuralgia to actually give a point dose to the trigeminal nerve. You can give the dose to the treat the tumor first, and then look for the response. And they do respond quite well.
And how about the side effects of stereotactic radiosurgery for trigeminal neuralgia? Like a lot of patients may have hyperesthesias, which can be transient to permanent, and also going about numbness. Is it like based on the lesion that you create, or the brainstem dose you would like to enlighten with?
So that has been extensively studied. Where are you going to target it? Because as the Laxel started, he used to target the Cassarian ganglion. Yeah. Later on now, the practice is to target the cysternal component of the trigeminal nerve. So if you are close to around 6 to 8 millimeter away from the origin, from the brain stem, that's usually traditionally called the Marseille point. If you target at that area, your pain control is good without any sensory complication. The nearer you come to the brain stem, the chances of the pain control are nearly the same, but it comes at a cost of sensory hypoesthesia or numbness. Most of the time it's a trade-off between the sensory complication and the pain control. So if there is a little sensory complication, sometimes the pain control is still longer lasting compared to the one where you do not get any sensory hypoesthesia, and it is hardly ever a bothersome hypoesthesia.
Unlike NPD, both RF lesioning and SRS gamma knife are destructive procedures. So a bit of sensory loss is definitely expected. And in fact, the patients who have 10 to 15% sensory loss at around say 6 months follow-up generally are the patients who tend to do very well over a long period of time. So I don't think 10 to 15% is going to be that important. But another interesting cases, some which you have done are the Sant and Suna syndromes, and which we published in of headache and pain. So in those cases, apart from targeting the trigeminal nerve, we also combined it with targeting the sphenopalatine ganglion. So we gave 2 shots, one to the trigeminal nerve and one to the sphenopalatine ganglion in the same sitting, and both the pain as well as the autonomic symptoms of Sant syndrome were relieved. So this is another way of targeting. Of course, there have been debates on as to which target is good. We generally use the Gasarian ganglion just where it enters the Gasarian ganglion.
Retrogasarian.
Yeah, the retrogasarian target. The advantage is both the Gasarian ganglion and the brainstem are actually fixed points, while the cysternal component is a mobile part of the nerve. So there are arguments both for and against, but we have used the pre-Gasarian targeting.
So we come to your target location and your doses. So
that's one of the most hit questions these days. And it's an excellent question as far as the current discussion on the BD is also concerned. So the dose which is usually prescribed, the prescription dose is 70 to 90 grain gamma knife. That's at the 100% ISO dose. That's a 4 millimeter shot. Anything which is less than 70 is usually not effective. More than 90 is actually an ablative dose. You do not want to create a lesion inside the nerve, but you want to do a sort of a radiosurgical neuromodulation, and that is achieved in this dose range. In my personal practice, anything which is more than 84 gray, that's a good dose. And there are certain technical nuances like avoid the beam blocking and the beam shaping, and just give a point dose rather than involving a longer length of the nerve. And that's a good enough dose to create a pain-free period.
So you prefer anterior cysternal? Yeah. Dr. Dwarkanath said retrogasarian.
Yeah, that's the same.
So but you stay away from the root entry zone. Close.
Because as far as the trigeminal nerve is concerned, the root entry zone is a fanning thing, which is not exactly a zone. It's an area actually which need to cover, and it's very variable between the individual periods. So you need to be somewhere around 6 to 8 millimeter away from the origin, and that way you can keep your brainstem away from the 30% ISO dose while targeting the nerve. So you are like a sniper shot, and then you are safe.
Okay, I would like to ask Dr. Manas, like first failed MVD, what would you do? Fit patient for surgery?
is a failed MBD, which we suggest either repeat RF or a gamma knife, depending on the affordability. And if it's an atypical trigeminal neuralgia, means if they do not have the classical symptoms, means clinically, as you know, there are two types. One is episodic, and one is hemifacial free and continuous. So in the episodic one, they do better. So it's not only on the targeting, also it's on the clinical symptom, also the outcome differs. So if you failed surgery, I send for radiosurgery.
Okay. So I would like to ask Dr. John Adler or Dr. John Adler if they can tell about how is the targeting and dosing different in Zap now, because what we had discussed were all the data for gamma knife before and cyber knife. Is there do you take 50% isodose line, 4 mm targets, same as gamma knife for Zap?
Well, since I've yet to treat a patient, it's sort of presumptive of me to tell everyone how to do it. Since I've yet to treat a patient, it's been presumptive of me to tell anyone how to do it. But what the Zap-X will give you is a even steeper dose gradient than was ever possible before with the gamma knife. So you can re-examine what part of the nerve you want to treat. You could potentially, and you should be able to go closer to the brainstem should you choose to want to. Of course, the risk, as you know, of going close to the brainstem is, I think, a greater efficacy, but a greater risk of facial numbness and paresthesis. But I'm going to challenge the group here to think about trigeminal neuralgia differently for a second. And I mean, it was really by happenstance that we decided to target the root entry zone initially, and it was Lexell, in his enthusiasm for radiosurgery, didn't know what to be done, so he had his student Hawkinson say, well, see if we can at least image the Meckel's cave, and that's where they came up with glycerol rhizotomy in the process. But it was always, imaging is what drove the targeting decision in the past. But since trigeminal neuralgia is not a disease of the entire nerve, it's a disease of the divisions. So I'm going to ask you, why are we not making what I would suggest is the next step, doing preganglionic and treating the divisions rather than treating the entire nerve itself? So I was supposed to answer a question. Instead, I'm going to ask you the question. Anybody, is there a reason not to do that?
Since you are taking me back to the Lexell era, you remember that the dose that he gave was pretty less. It was 17 to 18 gray, and still then the patient had a pain control for 20 years and 22 years.
Yes.
Those two patients. So if I have to, in the retrograde, I have to answer Gaurav's question, what should be an optimal dose? Practically nobody in the world knows.
Correct.
Nobody in the world knows.
No one knows the correct dose, they don't know the correct target.
Yeah.
And that's why I don't want to be too dogmatic here.
So probably it's an open question still after 7 decades, and we would be probably better in the coming decades also with your experience and the other machines. But as far as the dose and the BED is concerned, it would remain an open question for the coming 1 decade more, I think.
I think we all agree that when they started off the root entry zone, then they went to cistern segment, they used to put multiple shots along the course of the nerve, and it used to cause a lot of paresthesias, all the sensory disturbances. Then using the beam blockers, trying to get the brainstem, get the skull with the 30% isodose line to the outer contour of the brainstem. It used to be a big mess. So we kept on moving forward and ended up with the. But your question is very well taken. Why not?
Well, the Zap-X is going to make it easier to treat anywhere you want along that nerve. So it's easy. But is it the right target to start with? And I think it's important to just ask what is a pretty fundamental question. So, because when you do a rhizotomy, of course, you're trying to pick off the division. You're not per se trying to treat the entire nerve itself. So, but food for thought.
Okay, you recently published a paper on biological effective dose and for trigeminal neuralgia. Does this neuromodulation has a disease? Does it limit the disease progression? Demyelination? Does it stop with your radiosurgery?
Whenever there is a study now on a BED, the results are, there are no results, there are questions, because that's just playing with the statistics in the different studies. BED is one thing which people are questioning against the prescription dose, and our understanding about the BED tissue repair during that period is still not settled. Yes, there are groups which have now started calculating the prescription dose according to the dose rate and the decay of the source. Accordingly, they are giving it, but the results are still not clear for that. Even in my study, which included close to around 700 patients worldwide, we couldn't come to a conclusion. So BED might have a role, but should that be given a preference to the prescription dose? That is still not clear. It has been found that the patients which have been treated when the source was new and the BED was pretty high, the pain control was better, but it came with slightly higher risk of the complications of the sensory hypoesthesia compared to the one when the source is old, the treatment time is longer, the pain control is practically the same with lesser sensory complication. So that's the only interpretation which I could make so far. But what should I give a preference to? Still that question is unclear.
Dr. Chaudhary wants to ask a question.
Thank you. It's little different. Gaurav is coming to V1 involvement. Is there any preference for radiosurgery then? Because you avoid doing RFA in V1. So what could be the choice of?
Sir, if you allow me to answer this question, I consider trigeminal neuralgia as an orphan disease with multiple fathers. Everybody, whosoever you go, neurosurgeon, pain physician, neurologist, anyone, they all say that they treat the disease, but nobody takes the guarantee that they would really treat the disease. And while discussing the treatment options, we sometimes discuss like a businessman when the RFA guys say that you might have a sensory complication, but you will get a better pain control. So it shouldn't be like a bargain between the pain relief and the sensory complications. So those all options, the duration of the pain control, the latency of the pain control, and the need of the repetition of the procedures, that needs to be weighed with the patient, and that needs to be honestly discussed with them. Yes, every treatment modality has their place as far as the trigeminal neuralgia is concerned, because we practically do not even know the pathophysiology of the disease so far. In the early stages, in the later stages, we are still unsure about it, and there are so many factors which are playing, like the vascular compression, no vascular compression, secondary ones, multiple sclerosis, so we do not have a definitive answer. Every treatment modality has its role, but that needs to be honestly discussed, and probably that among all the treatment options, I say that the best response is still with the MVD, and that provides you the longest pain-free interval and an immediate pain relief without the need of the drugs. Because when we discuss it, we just keep BNI 1, 2, 3 in a single category, that's a good outcome. As far as I am concerned, BNI 1 is the outcome. That you should be pain-free without the need of a drug. If you are pain-free with some need of a Zap-X, means carbamazepine or something like that, then that's not your ideal outcome. An ideal outcome is pain-free with no drugs.
But my
and
question
that's best with them.
My question was for V1. V1.
Ophthalmic division.
Oh, sorry.
My question was for
ophthalmic division is there, then either go with the MVD or with radiosurgery, not with the RFA, because you can get that.
That was I was expecting, because RFA.
RFA is contraindicated in that situation.
Okay, any more questions for trigeminal neuralgia? So we quickly move on to tremors. No, sorry, I'm sorry. No.
Trigeminal neuralgia, and he is asking for, radiosurgery. So what do you do? Is there any age limit by which say that, okay, in the younger age group we should not do radiosurgery?
So there is no age limit. It's not that they're bad candidates, but if you look at response rates as well as long-time pain control rates, the rates of control with surgery are much lower, much better than gamma knife, SRS. So the problem with SRS, gamma knife, what we've had is out of 100 patients, 70 patients respond very well, and these are the persons also who have a long-time response. But there's a group of 30% who do not respond to gamma knife at all. So I mean that is what it is. The initial response rates versus long-term response rates are much better with surgery. You can still give gamma knife. It's not wrong, and because it's not an invasive process. Your surgical field later on, if it fails, is also not going to change much. Unlike RF lesioning, where the arachnoiditis occurs, there is thickening and surgery becomes more difficult. Gamma knife, there is no discernible change on the quality of the surgical field post gamma knife failures.
Can you repeat it again after a few years? Suppose the patient comes back
So if
with
you
the same dose, like
after
80 GY.
So we use around 80 to 85 grays to the 100% isodose line, 4 mm short. So,
Patient comes back after 5 years, for example, or 10 years, with after you give an SRS, what do you do?
So if for any reason we have given gamma knife, where surgery is also feasible, I think the second for me would be surgery, not redo gamma knife. But we have given gamma knives after five years. We have, but it's not my choice.
So you can give it, and the time interval between 2 gamma knives up to SRS is not a definite one. There are groups like from the Christopher Dumas who give it for 3 or 4 times to their patients, and that to an yearly interval. Now, where's the sweet spot in those patients? Should you just treat that same area, or you need to move a little bit? In those cases, they usually move 2 to 3 millimeter anteriorly, and they slightly reduce the dose. Earlier, if they have given 90 or 80, then they just settle on the 70. And those are the patients, they usually choose the patients who earlier have responded well to the first radiosurgery and then had a recurrence. Only in those patients they have tried it. If they fail the first radiosurgery, then they do not try it. That's similar to my practice.
Yeah. Hello.
Sir.
From the neurologist perspective, the secondary causes like multiple sclerosis, we have a definitive treatment there. The patient comes with trigeminal neuralgia, especially in young ladies. We have a problem with gender there as well as the age. So what do you prefer and how do you do?
Partial rhizotomy. Under neuro monitoring, the rhizotomy provides the best pain control. So because in my experience, and since this disease is more common in Canadian and all those areas where multiple sclerosis related trigeminal neuralgia is much more prevalent, the pain recurrence is close to around 70 to 80% by the end of 1 year. So that doesn't provide you a long-term pain control. And finally, those patients go for a partial rhizotomy. That's the only thing which gives the pain relief in those patients.
So you do it in the beginning itself straight away, or you do other procedures and then go to the rhizotomy?
So patients do not agree for a primary destructive procedures. So yes, they go for the alternative options. So I say that let them buy that treatment rather than gift them a treatment. So in that way, it's a step ladder approach.
All right, we move quickly to tremors, and Dr. Manas, you'd been doing deep brain stimulation for quite some time. So I would like to have your thoughts on the new techniques like stereotactic radiosurgery for tremor syndromes versus HIFU, which is also coming up nowadays. Your thoughts on the alternatives to DBS?
Yeah, means for Parkinson's, there are 2 types of treatment. One is lesioning and one is stimulation. DBS is stimulation, it's more physiological. Among the lesioning, we have the age-old radiofrequency lesioning, but then because of side effects, people have moved to stimulation. But then with now, because people don't want surgery, people don't have a risk for surgery, have a high morbidity, they're not fit for deep brain stimulation. Now they prefer either radiosurgery or focused ultrasound HIFU. But then there is a significant difference because when you give a radiosurgery, it takes almost 3 weeks to 3 months for patients to have an effect, and one cannot do any testing during the procedure. So the side effects are little higher in radiosurgery in tremors, whereas when one uses focused ultrasound, it is done with clinical monitoring. One can do the neurologist can be in the MR room, do the testing, and increase the dose of the ultrasound energy source and do the listening. So the side effects are less, and the effect is immediate, like a radiofrequency listening. So if one has to offer all the 3, radiofrequency and radiosurgery followed by ultrasound, HIFU ultrasound, probably ultrasound will score over because it has the advantage of testing as well as less side effects. That's my opinion.
I think that's a fair opinion. I think that's the general opinion. And we have tried, I mean, we have some of the largest series of RF lesioning for tremor. And I mean, like what, we have almost had 100% response. You yourself have seen those patients. It's a very good procedure. I mean, gamma knife is also a good procedure for lesionings. I mean, again, the targeting is precise. The only drawback, as we have seen it, is we have used it in a few patients. The response is not immediate, so there is no intra-procedural feedback as to whether the tremor is actually responding or not. And that is the main drawback of SRS for tremor lesioning. So HIFU again is good, but it's very expensive. And I'm not sure about the affordability of HIFU for most of the Indian patients, but it's a very good measure because of the intraoperative feedback.
No, but one of the drawback of HIFU is again one cannot do bilateral, and the results are 5 years. We have only 5 years of follow-up data. Unlike DBS, whatever the data in the literature, that the DBS, the long term, because it can be done bilaterally, the outcome is better than using HIFU or radiosurgery. It's more for if you have a tremor predominant, unilateral Parkinson, radiosurgery probably will be better, or HIFU, but if it's a bilateral disease, deep brain stimulation will be better.
That is an important caveat, that unilateral tremor lesioning is a very good option, but for bilateral tremors, deep brain stimulation is the better option.
So you have done both in RF as well as stereotactic radiosurgery, and you once said that our neurologists are not ready to wait till the effect of radiosurgery comes. So we prefer RF.
The problem with neurologists, and I hope sir forgives me, is that they are very impatient with us. Yeah. So the neurologists are very impatient with us. So unless they see immediate response, they say they think the procedure has failed. It has not failed. Actually, the patients did well, but again, that delay and all that.
We have a neurologist on board, and we'll just have a.
No, but ultrasound is not without complications. We have had patients who have done very well. We had patients who have had difficulty in swallowing after the procedure. We have people who have been sleeping after the procedure. They sleep and they need some sort of a medication to keep them awake. So it's always better to explain to the patient that they may have swallowing difficulties and sleep-wake and sleep disturbances. So, but look at radio frequency. We always tell ahead of time. When we always work as a team, and then we always tell, okay, this is what it's going to be, and we prefer now doing a little more DBS because we've got excellent leads and excellent software for programs. So I think it just shifts according to time.
So yeah, I would.
Among all the surgical procedures which I have done, I think tremor lesioning for tremor is actually provided a 100% response in all patients. So I'm extremely satisfied with the procedure.
So I would like Dr. Manjul Tripathi to say that tremor is a pass for radiosurgery.
If I say in Hindi to you, if you remember one old advertisement, wahi safedi wahi jhaag kam daamon mein mile to koi ye kyun le wo na le. So the radio frequency ablation, which I can do at 0.01%, 0.001% cost of the HIFU, I would definitely offer to my patient population because that's providing an immediate result. It's a standard procedure. As far as the radiosurgery is concerned and the rest of the things are concerned, which has been spoken, I totally echo in their sentiments and in their opinion. One important thing is that with radiosurgery, you go with a staged procedure usually. Again, you can't do bilateral in the same sitting. The second problem, sometimes the patient is radiosensitive, and in those cases you try to make a 4 millimeter lesion and it may get translated into 1 centimeter or something like that, and then the patient may land up in a complication. So that's why I keep RFA on the preference for these ones. I have done for essential tremors, even for the home tremor, and have received the good results. But one in a while, it means somewhere around out of 25 patients, one patient turns out to be a hyper responder, and I do not have a earlier recognition of those patients that they may turn out to be hyper responders. So yes, that's one complication is there with surgery.
Can you just brief the audience about the dose that we use for?
Gradually we have been becoming more and more restrictive in the dose. Earlier when we started, we were with 160 gray, but then we reduced to 140 gray, and now at 130 gray also we are getting that good results. There are series which have prescribed at 120 gray, like the Mars group with the jaw ridges, So they have, with 120 gray, their results are equivalent to the 140 gray. So yes, the doses are gradually coming down, but 120 is an okay one.
Right. Any questions from the audience about lesioning in movement disorder using SRS?
Two more things, Gaurav. Sir, regarding the HIFU, it's also dependent upon the thickness of the skull. The patient needs his complete head to be shaved off before he goes into the gantry. So both of them determine the outcome of the lesion size.
Okay, when sir, please.
Regarding these ablative procedures, another problem is the effects start wearing off after some time. That is also a big problem in these patients. So either you have to make a bigger ablative procedure, you have to increase the size of the ablation, or again you have to go to the DBS. So I think DBS is still the gold standard right now. And again, you already said the bilateral procedure is definitely going to harm sometime.
Parkinson is a progressive disease. What you are talking is for about 5 years of good life. Then definitely the symptoms will get on. Sometimes it will become Parkinson plus and will get cognitive things. That's part of the disease. So there will be, as you rightly said, recurrence of symptoms in most of the patients after 5 years. What do you think?
Yeah, means I agree with you that recurrence will be there. Means DBS also only means sometimes it can means the progression of disease, the rate of progression can be reduced, but it doesn't treat the disease, stop the progression. So whatever method is done, some other method has to be repeated, and but then in DBS cannot be done. Patient has a cardiac disease. They have a high chance of having heart attacks and all those. So normally we do a dobutamine stress echo before suggesting for DBS in cardiac patients. So cases which are not fit for DBS, they are fit for either lesioning or radiosurgery or HIFU.
Okay, we also would like to discuss about stereotactic radiosurgery in cases of epilepsy. And I know it's a little vast topic, lesional versus non-lesional, temporal versus non-temporal, but can you just give brief updates on what are your thoughts, what are the updates and indications?
So divided into the lesional epilepsies and the non-lesional epilepsies. For the multiple temporal lobe sclerosis, there was a very famous trial called the ROSE trial, which was stopped in between because of the several reasons. But if you go with an interim analysis of that one, after the anti-temporal lobectomy, the seizure-free outcome was in 71% compared to the 54% the patients who received the radiosurgery, and many of those patients had actually developed the radiosurgery-induced edema. So the trial was stopped, and it was confirmed that the anti-temporal lobectomy is much superior to the stereotactic radiosurgery. But when these patients prospectively followed for a longer duration of time, down the line 10 years, the seizure-free outcome became similar to both the procedures. But so far, it's not the preferred ones. If you go with the lesional epilepsies like the cavernomas, hematomas, hypothalamic hematoma, so in those cases, if you treat early in the natural course of the disease, then the seizure-free outcome is pretty good. And if you wait, then it becomes difficult because again, it just doesn't remain a focal disease, it becomes a network disease, and then you do not know how much area needs to be irradiated. So better to intervene surgically under neuromonitoring in those patients.
And a final question, we will neuromodulation has brought the neurosurgeons back again into the psychiatric domain. You know, it started with lobotomies initially, and now we are back again with DBS. And Dr. Dwarkanath is part of a multinational trial, which I was also fortunate to have seen cases we have done DBS for OCDs. So your thoughts for stereotactic radiosurgery, OCD, de-addiction, anorexia, bulimia, is there the list? What do you think?
I mean, let's keep OCD aside for Alzheimer's, for addictions, for bulimia, for anorexia. All the studies are still experimental, while OCD is the only condition in which the FDA has given approval for deep brain stimulation. Having said that, we have done both lesionings and deep brain stimulation for OCDs. I think we have around 11 patients each in both arms. Results are actually quite satisfactory for OCD deep brain stimulation, OCD gamma knife. We generally treat the ventral, anterior and internal capsule, and out of the 11 patients, we have had analyzed 9 patients, out of which around 6 have had a complete response in the Y-box score, while 2 are partial responders in the Y-box and 2 have not responded. The DBS, of course, has proved to be much more effective. I think the interim results will be published soon, or we have sent it for publication. Out of the 11 patients, again, we have done for deep brain stimulation, 9 have been available for analysis, and 7 have shown complete response on the Y-box scoring. So these are all treatment refractory obsessive compulsive disorders who have completed OCT, who have completed cognitive behavioral therapies. So the results are good, and in fact in the 2021 recommendations on psychiatric surgery, and as well as our own recommendation of the Indian Psychiatric Working Group, OCD is one of the indications for either lesioning or deep brain stimulation in treatment refractory obsessive compulsive disorders.
The comorbid associated depression, anxiety, that also gets better in some, and the dose of medication also is reduced in the group of patients. And also there is somebody who is doing cingulotomies as another target for OCD patients.
Yeah, so we did, out of the 11 cases, we did 2 cingulotomies and 9 capsulotomies. The problem with cingulotomy is, again, it's a large area and you need multiple shots, while the internal capsule is a much more compact target to target. So now we have shifted over to the ventro-anterior internal capsule.
I think the earliest surgeries for OCD and for drug addiction was done at the Madras Institute of Neurology by Dr. Balasubramaniam and Dr. Kanaka. These are extensive surgeries.
Kanaka was kind enough to give her sheaf of thing to donated it to NIMHANS actually. So I have it with me. So in fact, the largest number of cases was done by the Madras Neurology group.
I love radiosurgery for anti-capsulotomy because of the simple reason the patient is not feeling like he is under control of some foreign agency like a cyborg. The results are pretty long lasting. You can do bilateral anti-capsulotomy. You shouldn't go with the checkered history of the of the psychosurgery. It's one indication which gives excellent results, and even the results in in this severe depression are coming pretty good. Yes, the targets are evolving, but as far as OCD is concerned, the results are now pretty settled. And even the JAMA published a study from the Brazil, it has been found that the patients were much better with the radiosurgery compared to the DBS. So I find that I encourage the psychiatrists to send those patients rather than just keeping on behavioral therapies and all those things.
How do you go around the mental health board?
That's a burning question since 2017 with the Mental Health Act. But I think we should encourage, like the neurologists encourage for the movement disorders, the psychiatrists should come forward for the psychosurgery.
Sure, we're going to see the other indications with Dr. Adler will present his work. Let's see. Yes.
What about patient intractable pain? Do you get referrals for radiosurgery, looking at the PMN, looking at the posterior median, for cancer patients, but half of them, I believe, respond. Can you give us some insight into it?
Radiosurgical hypophysectomy, it should be the, so that's centromedial nucleus of the thalamus, that's usually target, but but if you are talking about the cancer related pain with the patients with the bony metastasis, and the radiosurgical hypophysectomy, it provides an excellent relief in those patients. It should be actually the last step of the WHO ladder. It's still an underutilized indication, and it should be used as the palliative radiosurgery in the common practice. It's still being not used.
Right. Thank you. Any questions, any comments from the audience? So we're good. Thank you for an enlightening session. So, sir. Yes.
Sir, no more radiosurgery in dystonia. The problem is that the GPI is pretty rich in iron, And so it's a very radio-sensitive target. You try to make a 4 millimeter lesion, it may expand, it may go into the internal capsule. I have burnt my fingers. So I have stopped doing it. Then the problem is that those lenticulostriate arteries are very, very, you do not know how are they going to respond to that radiation. So GPI is not a safe target for radiosurgery. It should not be practiced. In my opinion, you have better alternatives like radiofrequency ablation and the DBS. But as far as the GPI is concerned, I do not want to give radiosurgery anymore.
It's a fair comment. I mean, because the GPI of large area, sir. So you have to give a higher dose, higher area, and spillage is too much. Radiofrequency ablation is very safe, even for hemidystonia. Otherwise, bilateral, it would be deep brain stimulations. Yeah, done. I mean,
actually, Chavra and I have given Paresh Joshi a couple of patients. Quite good.
Thank you so much, our esteemed panelists, for an enlightening discussion on indications beyond the routine. Thank you so much. I'll take Fawzia to take over. Thank you.
I please request the panelists to stay on the stage. Mr. Harshad Reddy, please to come on the stage and to felicitate the panelists, please. Moving ahead on a quest of unveiling the intricacies of SRS and preparing for a deep dive into the technological marvel that is transforming medical landscapes. Our next speaker for the scientific session is Professor Maximilien Rouge. Professor Maximilien Rouge is Professor for Oncological Stereotaxy at the University of Cologne. He heads the Division of Oncological Stereotaxy and Radiosurgery at the Center of Neurosurgery, University of Cologne. Professor Maximilien's areas of interest are stereotactic radiosurgery and brachytherapy, clinical neuro-oncology, both adult and pediatric, stereotactic OR techniques, and imaging in neuroscience and neuro-oncology. Professor Rouge would be speaking on SRS in treatment of cerebral metastasis in context of modern interdisciplinary oncology. The chairpersons for this session are Dr. Srinivasan Parmasivan, Dr. Abida Shah, and Dr. Krishna K.N. May I please request the chairpersons to please come on the stage?
And this is a slide changer. If you want to slide change.
And can I use this one as well?
This is for
okay.
Not for you have to click to change it.
So we just have to start.
You want to click here for change the slide. Just here.
Okay.
So, dear Dr. Reddy, dear family of the Reddy family, dear hosts, dear organizers, dear colleagues, dear chairman, thank you very much for inviting me to India, which is for me an exciting and beautiful country. And always, if I get to a trip to a country which I don't know, I'm always asking myself what is expecting me there. And I can say so far, I have experienced a lot of graciousness and hospitality, but also a lot of interest and knowledge. So with my presentation, I may only try to give you a humble thought about some things which I'm thinking of, and I give you a humble insight of what we do as a radiosurgeon in Cologne and in Germany. So this is where I come from. Here you can see India, and this is quite some trip to east and west, and then you will find Germany. And then within Germany, when I was born and raised in Munich, but now I'm working and living in Cologne. And Cologne is famous for its big cathedral, and also hopefully a little bit for its university campus, the University of Cologne. We have more than 1,500 patient beds and institutes and departments, over 60, from basic science to clinical applications. We have more than 12,000 employees, and since we not only have a medical school, we also have a school of neuroscience, nursing, medical economics. We have a lot of students to teach, and the inpatient caseload is about 60,000 per year. Outpatient caseload is about 350,000. So now you know where I come from. The radiosurgery department, or the radiosurgery we do, we have been always in the responsibility of the Department of Stereotactic and Functional Neurosurgery, so my department, and it's operated by neurosurgeons which are skilled in radiosurgery. So far we have treated since 1990 with a modified Linac, which I will show you later, until 2011. And then, and this is what you are ahead of me, I'm still using a CyberKnife, so excuse me for that, but at least it has been the first one in a university setting in Germany. However, we have treated more than 5,100 patients with both systems, and as of now, the caseload with radiosurgery is 250 to 300 patients per year. Now, what is the caseload? What have we done so far since the last over 30 years? And this is why I chose my subjects to talk about brain metastasis, because at least in our clinic, this is the majority of caseloads, and most likely it will be in your department and your clinics as well. Other than this, of course, meningioma, vascular, pituitary, AVMs, and so on. So what is my agenda for my call today? I would like to talk about the techniques and the procedure, which we have seen already a little bit, so I will go through this very quickly. And then I would switch to brain metastasis and the role of stereotactic radiosurgery in over time with regard to treating brain metastasis, and what is the status of today and what might be future perspectives. So first of all, I mean, there is a lot of different radiation which you can apply to a brain, to a skull. And first of all, I mean, this is just a fractionated, which you do for large tumors, where you have a large volume to treat, and so you give little fractions over a very long time to do the effect. The complete opposite is radiosurgery, where you focus a beam which comes from different directions, and then it focuses on on lesions which you need to well subscribe. And then this will happen in minutes to hours maximum. And I'm not just mentioning this because I love to do this, and I'm trained in this, and there are not so many people around who still do this. It's brachytherapy, especially for low-grade gliomas in children, where you put the radioactive source into the tumor. But this is not the subject of today. So now, as you have seen already, you need a target to which can be identified, like this vestibular schwannoma. Then you have some kind of head fixation, either with a frame, which is, thank God, less and less, but now we are moving more towards masks. And then you have a kind of imaging system which will help you to guide and to track your target, and you have bundled beams coming from various directions, and they are focused on the target, as you have learned before. What is a little bit the evolution of radiosurgical techniques? And if you think about that, radiosurgery is around for more than 70 years of now. Yeah? Most of us have not been around at this time. It was invented by Lars Lexell. And so the evolution is still going on with regard to the gamma knife. Yeah? But I mention this because my former chairman, Professor Volker Sturm in Heidelberg, wanted to have always a gamma knife, but he couldn't get one. So he tried with two physicists to develop something different. So he modified a linear accelerator in a way that they could do radiosurgery as well. And then I don't know whether you have heard of this guy, but this Professor John Adler from Stanford University, I imagine him as a young person who's going to Karolinska and is impressed about what he sees. But as an entrepreneur, as a really highly intelligent person, he thinks, how can I get rid of the frame? How can I develop something which is not depending on fixating a head? And so he makes radiosurgery see the patient. And this is, I think, one of the greatest jobs. But being an entrepreneur, he couldn't stop inventing things. And so he invented also the Zap, which we inaugurated yesterday, a wonderful machine. And if he says, well, it's developed for just the brain, I must say one of the advantages I see that it's basically shielded in itself, so you can put it anywhere in your backyard and run it, and you don't need to build a bunker. And I think that's something you should mention. Here, this is the Cologne protocol. We do for every patient a complete new set of highly resoluted MRIs in order to get because you get different informations as we go through the different sequences, because, for instance, the T1 always exaggerates a little bit the volume, the T2 and the volume images will help you to identify cranial nerves, and they give you a different point of view. So the sum of all of this, including now the CAT scan with bone window and with soft window, you have a lot of information that you can accurately outline the tumor. And this is inverse planning. We have heard of this. This is like multiple brain metastasis. And here you can see the beam distribution. And here also what is, I think, so interesting about the system, no matter it be a CyberKnife or a SAP, is that you have this inverse planning. So here is your target, which you need to give the highest dose. And then you have those restriction areas where you say, don't give any of the radiation, or just give less radiation, for instance, for the optic nerve. And the program and the machine comes up with a suggestion, and you as a physician might then choose with your physicist, is this okay for us? Can we do this like this? Here you can see the CyberKnife system. Again, I don't want to go too much into it, but as I said, the good thing is that the system is looking at the patient, and then it's the robot is moving towards the different and to apply the different beams. Here, an example of a brain metastasis, a patient which basically came to our attention with a hemiparesis on the right side. You can see this tumor, a lot of edema. It's pretty eloquently located in the central sulcus area. And here you can see the follow-up. You do the radiosurgery, and then the patient is on steroids. And just a couple of weeks later, you can see that the metastasis is responding quite quickly. The neurology is improving. And if we look 16 months later, and the patient was lucky because he had a very favorable systemic disease progress or not progress. He had no deficit. He started to play tennis again. And so this is quite a success if this patient comes back to your outpatient clinic. Now, what are the indications? And I showed you brain metastasis on number one, at least in our daily business. Vestibular schwannomas, meningiomas, all the things we have heard before. This is what the targets are for stereotactic radiosurgery. And of course, what I learned as well, and what we all learned now, that they're more and more thinking about functional targets. So now, facts about brain metastasis, and this is what a major topic of my presentation is. Yeah, well, there's an increasing incidence of brain metastasis. Why? Because we have more and more MRI imaging available, and the MRI imaging gets better and better. So we have an earlier screening, for instance, in Germany. Every patient with a lung carcinoma newly diagnosed, same with skin cancer, gets an MRI of the head in order for screening for brain metastasis. And since the systemic therapy improved, and I will show you this later, you will have a longer survival. But the problem is that your patients will survive longer in order to build out brain metastasis. So it is increasing, it's an increasing indication. And if we talk about brain metastasis, as much enthusiastic we are about techniques, it's still for the majority of your patients a very bad news. Yeah? And as we know, what are the prognostic factors? It's age, it's the Konovsky performance score, it's how many intracranial tumor volume do you have, what is the systemic status of the disease, and some GPA scores, including histological and molecular features. Yeah. If we look at brain metastasis, and these are all patients with brain metastasis, and you can see that this is there's so many variables. The neurosurgeons among you might think, okay, I'm going to take this one. Oh, this is not so easy to take, and I can take this one, but what to do with the rest? The radiation oncologist says, I'm going to wait for this one. So there is many different things having all brain metastasis. And there's many things which we have to consider in order how to treat our patient. Now, we know resection, we know irradiation alone, locally, whole brain radiosurgery, medical treatment, or combinations. What to do for whom? And now we can take different perspectives. Now, we look at just the patient, yeah? And if we look at the patient, you can say, well, there's an age, a Konovsky score, and what is the medical condition of this person? Even so, it's a right frontal brain metastasis. Can I treat him because can I operate on him or not? Yeah. What is the systemic tumor status? Is he stable since 10 years because of a breast cancer metastasis, or is he just newly diagnosed and is progressing with a tumor basically constructing the bronchus? So you might need to start with your systemic therapy first. What is the quality of life? What does the patient want? And then you look at the tumor, what size, how many tumors, how many metastases do I have, where are they located, what can I do, can I make surgery or not, what is the histology, is it small cell lung cancer, so they will be radiosensitive, if it's not, what kind of histology, are there potential targets for molecular or immune therapies, and what kind of time and sequence of the treatment do I have to take? I mean, as I said, do I have a first diagnosis? I need to progress rapidly, so the time in surgery might take the patient too far out for other treatment, or can I easily treat him with operation and so on and so forth? So, or should I bring him to radiosurgery in order to achieve a parallel treatment? So these are the questions you can answer. So now let's go back in time and say, well, this is very far, but this is 1950s. You had a heavy smoking patient. He got a generalized seizure. This X-ray shows this mass here, so most likely a cancer. And at this point in time, you said, okay, systemic chemotherapy, and he must have something in his brain. You didn't have any images from the brain then. And so you said, well, most likely it is going to be brain metastasis, so give him anticonvulsants, give him steroids, and send him home. So this patient was just living for 6 weeks. Yeah? And now a couple of years later, from the Memorial Sloan Kettering Cancer Center, this group came up and said, and this was, I think it was somewhat brave, if we think that this patient has brain metastasis, why don't we irradiate his brain? And so the whole brain radiation therapy came up, and it improved survival over up to 6 months now. We go way more back in time, and you see that we already have now a CAT scan, which is not really the highest quality, but you can see that there's something wrong here. And now we know the reason for the generalized seizure, because it's just a tumor left parietal, and this is why the patient had a seizure. And so what the study came out from Roy Petchel, that he said, well, if I have a singular brain metastasis and I do a resection and I do whole brain radiation therapy, which has been there, so this is the combination which we will improve the survival prognosis now up to 10 months. So we are getting better. Yeah. At the same time, and I'm sure that this is not the first work of radiosurgery in brain metastasis, but emotionally I have to mention it because it's my former chairman. In 1991, he described that radiosurgery can also apply And now we have an MRI. It's better, getting better with the imaging. And he suggested, why shouldn't we apply stereotactic radiosurgery? So we have operation, whole brain radiation therapy, and stereotactic radiosurgery. And since then, throughout time, there have been a lot of different prospective randomized trials. And as you can see, they are majorly driven by surgery. All the red bubbles are surgery in combination with whatever kind of radiation therapy, either stereotactic or whole brain. There's just 2 studies which compared these irradiation entities itself. Now, why do I show you? Of course, I cannot go into every study, but I would like to pick out 2, which, to my opinion, are the most ones which drove the new evolvement or the new evolution of how to treat patients with brain metastasis. It's the one from Martin Kocher. He sits next to my office in our department, and he looked at after surgery the use of whole brain radiation therapy versus stereotactic. And so he looked also at just what happens if the surgery, there's only surgery and there's only stereotactic radiosurgery. And if you look at this, and this ended a little bit the bravery of surgical thinking that you would do as much surgery as possible and the patient will be cured. No, it's not enough in case of brain metastasis. You need to add some kind of radiation afterwards. So I think this was very important. And the other study which I think is important and changed a little bit the way we think about things is the one from Brown. And they looked which kind of radiation should be applied after surgery to the patient. And they looked at either whole brain radiation therapy and stereotactic radiotherapy, but they looked at cognition. How did the patient perform with memory and attention after whole brain radiation therapy versus stereotactic radiosurgery? And you can see there's a huge significant difference in cognitive outcome when you do whole brain radiation therapy versus you do a local treatment. And unfortunately, and this is important, there was no improvement in survival. So if the patient is still having the same destiny, no matter what you do, then you should save his brain a little bit by thinking about what kind of radiation you will treat him. And now if we look at all the studies with regard to overall survival, did any of them improve overall survival? And I must say, unfortunately, not. So what is the results of the multiple trials we have seen? That there is no treatment combination improving overall survival. Surgery alone has inferior control, so you cannot just do just operation and do nothing following. Adding post-operatively stereotactic radiosurgery improves local control, but of course you don't have distant control because you didn't treat there. Adding whole brain radiation therapy improves local and distant control, but doesn't make the patient very bright after a certain point in time. So this is why you should be careful with this. So this is where we are left with all the surgical, radiosurgical, and whole brain radiation therapy trials. What is the status of the day? Why is it so exciting for me, in my humble opinion, to talk about brain metastasis? And the solution, unfortunately, does not come from us as neurosurgeons or radiation oncologists. It comes from the medical oncologists. Because if we look at this, here, this mass, when you do the sequencing, you will probably find a target for a specific immune therapy or a targeted therapy. Here you can see one of the good study, I think, milestone studies comparing in patients with EGF receptor mutation, giving a regular chemotherapy versus to osimertinib, an immune therapy. So you see suddenly that there is a significant survival advantage to the patient who get immune therapy with a receptor mutation than without. And if we look at that, most of the people who have an adenocarcinoma of the lung, more than 50% have a target which can be targeted by new drugs. So the challenge is now that there's a complete, frequently new drug development going on, not just for the primary phase of the systemic disease, treatment. So, but there's also more and more developed after for the recurrences which come in systemic. And it's interesting that some of the new drugs also can cross the blood-brain barrier, and they will somewhat have an effect on the brain metastasis. So now knowing this, that we have patients who suddenly can survive years with their disease, now we have to go back and look at with our tools and toys, which we have as neurosurgeons, radiosurgeons, and we look at this. Now, what have we today for this case? We have an improved imaging, the structural imaging, the metabolic imaging, and there will be soon IA-driven analysis of the pictures that they will show us even small metastases which are in the brain. We have more and more focus on cognitive functioning and quality of life because the patient is living longer, and so we have to preserve his cognition over a couple of years if he's responding well to systemic therapy. And the discussions are in our tumor boards not so much about glioblastoma, which take time. It's the ones which take time are the interdisciplinary discussions to develop a very personalized therapy for these patients. So we have to look at what kind of patient do we have, what is the status, what can any of us contribute in order to treat him. Now, if we look at stereotactic radiosurgery, no matter what system you have, I think all of them, and this is what we learned, it's not just 1 and 3 metastases and then the whole brain radiation therapy, then it was in the guidelines for a very long time. Now we can treat multiple targets, up to 10, 12, whatever. This is a very individual decision. We can do fractionated radiosurgery, 3, 5 fractions to large metastasis over 3 centimeters. So this basically this frontier fell as well. And of course, if a patient comes back after 6 months, after 1 year is presenting again with brain metastasis, you can repeat the radiosurgery treatment. So this is good news. The same thing is that we are trying out new treatment combinations. For instance, stereotactic radiosurgery to the resection cavity in order to save brain and not treat with whole brain radiation therapy. Or what I personally think is the most exciting, but we have to wait until the large and multiple prospective randomized trials will deliver results, is a neoadjuvant treatment. So you do radiosurgery first, and then you do the resection in order to save the patient from fractionated or whole brain radiation therapy afterwards, which is a lot of time which can be saved for a patient who doesn't have this much time. And the role of stereotactic radiosurgery and targeted therapy. When should we treat the patient now? If you have a patient coming up with these small metastases, leave this one out for a second, and so you have 3 ones, and do you want to treat right away, or if you know that this patient is responsive to a good systemic therapy and you have a targeted therapy which will probably help in the brain, so you may want to wait before you start radiosurgery. And again, this is a very individualized, personalized decision for the patient. And the challenges, but I cannot go into this too much, is the combination of stereotactic radiosurgery and a kind of targeted or immune therapy, because you might see funny things after 6 months to 8 months, because they might co-respond, and something comes up and you don't know, is this a real progression or is this a pseudo-progression? And plus, dear John, we wait for the next technical improvements. So what will be next after ZAP, we'll find out later in your talk. But of course, there will be a lot of technical improvements permanently. And I think what is, for me, intriguing will be what is the role of artificial intelligence coming into this and helping and showing us a little bit the brain metastasis. So to conclude my presentation, I would say stereotactic radiosurgery is a very, very old technique. However, under a very nice evolution, it was and is and will be always a safe, even more precise and even more minimal invasive, but still highly effective tool. You can use it alone, just treating brain mets only with radiosurgery, or you can drag it into a combined treatment in an interdisciplinary setting, and I think this is the most important thing. Think about it, the entire disease, in an interdisciplinary way. Of course, always as academic neurosurgeons, you need to make new treatment combinations, and they need to be evaluated. So thank you very much for your attention, and I'm happy to take your questions.
Thank you, Professor. It was an elegant presentation taking us through the history as well as the current era of stereotactic radiosurgery for the metastasis. Do you decide on doing treatment based on the proliferative potential of the primary tumor? Do you have a reservation that I would go for, even in today's era, I would go for a whole brain radiosurgery rather than an SRS?
I think, as I said, it is an individual decision. It depends on how many brain metastases do you have. It depends is there a potential for systemic therapy which will help. For instance, what we know, like from malignant melanoma, which was a deadly disease, it's a chronic disease today because you have all this immune therapy now. So probably you might not need to go ahead with multiple brain metastases to do whole brain radiation therapy. Sometimes you can postpone it a little bit and wait until your immune therapy helps. It depends. You always have to see what the patient is responding to. That's at least my opinion.
Excuse me. May I ask you, what is the role of status of brachytherapy now?
Excuse me, now I get this.
Brachytherapy.
Brachytherapy. Oh, I love brachytherapy. I think like this indication is large brain metastases who are highly eloquent. Brachytherapy, a completely different discussion, is for me great for brainstem gliomas, low grade in children. This is where it's the #1 indication. They are rare, but in brain metastases, we have shown data that, especially for the big ones who are in the thalamus, who are unresectable, and you would not, and they are too big for stereotactic radiosurgery, that are the ones which benefit from brachytherapy because they shrink in like minutes. Yeah.
Thank you.
How much margin you take while you're doing the SRS for metastatic lesions?
Excuse me, the question?
How much margin outside the lesion you take?
No margin.
No margin.
That's the point of radiosurgery. I mean, yeah. You get the surface of the tumor and you do this graciously, but there's no like 2, 3, 5 millimeters. There's no margin defined. Yeah.
And what is the number of metastases you can treat?
Depending. So if I have this patient coming to me having already had whole brain radiation therapy, comes up with 12 brain metastases, says, "Can you treat me, please?" Of course. Yeah. If you have a patient new into the disease, you might think about probably shifting him with 12 brain metastases to whole brain radiation therapy, and then have radiosurgery in the background when he progresses again. It is an individual decision. How old is the patient? What is the prognosis over time? Does he have a receptor mutation? Will he be around in 2, 3, 4, 5 years because of a beneficial receptor status for the systemic disease, or will he be dead in 6 months? So I think that's important, what you have to take into consideration.
Which is the largest number you have treated?
12.
In one patient?
12. But in one session. I mean, you know, we had patients who come basically every 6 months, again and again, and you will say, well, 2 at this time, 3 at this time, 1 at this time, 5 at this time, and as long as they come, well, it's an individual decision.
You showed data that survival was not different between SRS and whole brain radiation. Given the mutations in non-small cell cancer and the increased survival, do you think we need to revisit that, or do you see that we may revisit that with these patients with much better survival rates?
I think, well, don't use whole brain radiation therapy in patients at all if you don't need to. That's the first. Don't do it if you have a patient with a good systemic status and a potential to be treated for a couple of years. I know now cancer survivor from lung cancer, adenocarcinoma, who are after 5 years of survival, 10 years of survival. So be careful how you treat them in the beginning. And if we think about protocols like, Okay, so he has one. I know when I was basically getting into radiosurgery, we counted. So 1, 2, 3, 4 burned whole brain radiation therapy. Thank God we are, and also in the guidelines, we are away from this. It's an individual decision now, yeah? And I think I'm still having patients sometimes who have 2 brain metastases and get a whole brain radiation therapy. That's no-go now, yeah? But this is not so long, yeah? And I think this is hopefully answering your question.
There are no questions. Professor Maxwell brought out a beautiful, non-controversial subject for neurosurgeons, radiotherapists, or anybody treating with neuro-oncology. In the sense, we don't have a final answer for multiple metastases. Standard teaching in neurosurgery used to be a single metastasis, go and operate. We all know that it is a myth. A metastasis is never a single. It's only going to show up later. So you brought out in your slides beautifully. The option is a teamwork. The board has to decide and discuss with the patient what he wants, because it's going to be multiple attempts and it is beyond surgery or radiotherapy. We are looking for the third option also. And you brought it out beautifully. Thank you very much.
Yes, I mean, you have it's the typical case in tumor board, the patient with the right frontal brain metastasis. Yeah, and you know that the neurosurgeons are getting up tomorrow, this case tomorrow, and said, wait, he has metastasis all over the place. I'm going to bring him in a wheelchair because he can't breathe because this is huge tumor is like constructing his lung, yeah? You don't want to have him on the table, yeah? So that's a completely different story than if you have a brain metastasis in a female with breast cancer diagnosis, let's say 3 years ago, but with stable systemic disease. This might be a good case, but it's not the location of the lesion. It's always looking at the patient with all the different parameters. Yeah.
It's like the soldier is told, if there is one mine, another landmine will be there.
I have to say one thing, and I couldn't show these data. We have data from our clinic coming out that you say, well, you have this patient, he comes in with a Karnofsky score of 50 because of this mass in his posterior fossa, yeah? And so 50 Karnofsky index, wait, don't touch him. So you do touch him, you operate him. He has a Karnofsky of 90 after 1 week because you release the pressure from his posterior fossa. And suddenly this case gets interesting for the medical oncologists. And now let him have a receptor mutation. So what I want to say, the data show if you improve with your surgery the Karnofsky score of your patient, you will get him eligible for systemic treatment. He has a longer survival. And so the surgery has it's proving more and more in these cases it's that you should do it. So I mean, this is important, and it's now we are this far to say just not resect one, probably resect two, improve patients' status, and then you can improve the way you treat him afterwards. I think this is a very important aspect.
Thank you, Professor. What are your indications for neoadjuvant SRS?
Honestly, I would love to do it much more often if I could. However, we have a very restrictive university philosophy. Wait for the data, and then we'll see. We have done 10 cases, and we have 2 patients with a wound infection. So this is 20%. If you want to write up this as an abstract, and you write down 20% wound infection in your hand is cramping. You cannot do this because then you have the surgeons or anybody stand up and say, oh, you know, I know, neoadjuvant, you have 20% of wound infections complications. So we need to wait because I think this is just a coincidence, yeah? And I think what is so beneficial in my way, you can better circumscribe the tumor. And so I think this should be beneficial, and you save the patient a lot of time, yeah? Because you do radiosurgery, and 3-5 days later you bring him to surgery, and then that's it. You don't need to do a weekly focal radiation afterwards.
Thank you.
further questions from the audience? If there are no further questions, I think we will conclude the session. Thank you. Thank you all.
I now invite Dr. Madhu Sasidhar, our Chief Strategy Officer, Apollo Group, to please felicitate the speakers and the chairpersons. Professor Rouge, if I can have you on the stage, please.
I want to thank the entire panel and Professor Rouge. Fantastic presentation. Thank you all. In particular, I want to thank Dr. Rouge for at least showing one chest X-ray, so that was an image I could interpret. So thank you, sir, and all of you as well.
Over the course of this scientific discussion, we will explore the multifaceted aspects of SRS and particularly Zap-X. From technical insights to in-depth discussions, we will discuss how SRS has emerged as a powerful tool in managing AVMs, offering precision, safety, and favorable outcomes for the patients. How SRS has changed the management of intracranial AVMs. This is the topic of our next panel discussion. I now would like to call on Dr. Suneet Mediratta, Consultant Neurosurgery, Indraprasth Apollo Hospitals, to moderate this panel session. Dr. Suneet.
So good afternoon, everybody. We're now going to discuss a very complex topic in neurosurgery, which requires multimodality, interdisciplinary team work to manage, which is basically intracranial AVMs. We'll confine our talk now and discussion to intracranial AVMs because we now have a new stealth machine in the armamentarium of the neurosurgeons. So we will now, I would like to invite Dr. Arivaragan from NIMHANS Bangalore, our eminent panelist, Dr. Krishna Kumar, and Dr. Prakash Nair, please. And to chair this session, may I please invite Dr. Ravi Mohan Rao from NIMHANS Bangalore, please. So, sir, may I start with you? We all know that AVMs are difficult to manage unless they are small in size and have a superficial draining vein. Now, I would like to know your opening thoughts on what is the absolute indication to manage AVMs through radiosurgery, and what is an absolute indication to manage them surgically in your practice? And this is also open for people. We have a lot of faculty which is non-neurosurgery and non-neurology. So we like to have it be more informative for them as well.
Thank you. Good indication for both SRS and surgery is grade 1 and 2 AVMs. So what is good for surgery is good for radiosurgery too. Better indication for surgery is an AVM which has blood. As we know that SRS may take up to 1 or 2 years for the AVM to obliterate. In that intervening period, an AVM which has blood can rebleed. And we had instances like that in our own practice. Then AVMs located bang in the eloquent center, like a brainstem AVM, or AVM situated very near the motor cortex or language area, is a better candidate. Grade 1 and 2 AVM is a better candidate for SRS. Higher grade AVMs are not good candidates for SRS, like grade 3B, 4, 5 are not at all good candidates for SRS. In fact, they may not be good candidate for any treatment because partial treatment may change the natural history of the disease. An AVM which has not blood can bleed after partial treatment because of the change of the hemodynamics flow patterns within the AVM.
So there are reports which suggest that larger AVMs which are difficult to manage, you can at least reduce the risk of rebleed by reducing the size, by offering them partial embolization. What are your thoughts on that, sir?
Again, partial embolization is a double-edged sword. We have seen that when you do partial embolization, we have seen that in the early part of our careers where I was working in Sri Chitra, that partial embolization can cause AVMs to bleed because they can obstruct a vein. Now with the Onyx and with better tools, the chances of premature vein obstruction is very rare. When you use partial embolization, again subjecting these patients to radiosurgery becomes difficult. So for symptomatic management, the situation you are describing, I assume it to be like patient is having severe headache in a grade 5 AVM. Maybe reducing the size or changing the flow pattern may result in reduction of headache. That may be an indication for partial embolization. Repeated partial embolizations to reduce the size of a grade 5 or grade 4 AVM and then subject them to some other form of treatment is a very unusual situation. It's not a very common situation.
Sir, I'd like to know from you if you have an incidentally diagnosed AVM, because we now have so much imaging happening for different disorders. You know, incidental AVM finding on a slight headache or some paresthesia, AVM which is not in an eloquent area, about 3 centimeters in size. What will be your thought? How will you manage that? And what are we going to tell the patient, considering that the chances of bleeding in an incidentally diagnosed aneurysm is about 2 to 3% per year?
As you rightly said, the primary focus would be 2 aspects. One, what the rate of bleed, which may touch around 0.4 to 0.8%. If you take 1,000 people population, 3 or 4 might bleed. Second is the eloquence. So these will be the 2. And location, of course, supratentorial, brainstem, posterior fossa. So these would be the mainstay in decision making. It will be better to have a one-to-one discussion with the patient, relatives, and the grading of the AVM, of course, with respect to certain other factors like intranidal aneurysms. So this will be our mainstay. I would put a small example that recently which happened in my center. A patient was diagnosed to have a Chiari malformation. It was very simple. Surgery was done in the one of the hospitals by a single neurosurgeon center. The symptoms did not improve at all, and there was extensive edema in and around the region of the foramen magnum as well as the lower part of the cerebellum, the paravermian region. So out of suspicion, we evaluated, and there was some flow voids which were picked up in our MRI, and it happened to be a medial cerebellar AVM, which was the culprit for most of the steel and which was causing some kind of flow dynamics have changed after the foramen magnum decompression. So again, surgically amenable AVM, very good location, but after discussion they opted for embolization. Embolized, patient developed lateral cerebellar ischemic stroke. So this is the, so these are the incident, maybe it is incidentally detected, maybe it was managed for some other reason and got detected, but this is the course. So like Professor Raymond Rao rightly pointed out, the best of surgical lot would be the best for SRS. All options need to be explained and weighed with the risk as well as beneficial.
Sir, question for you. A small AVM in the motor cortex or in the eloquent area, speech area, what would you like to do? What would you like to offer the patient?
Yeah, before I go to that question, I would like to answer first few questions what you asked Dr. Raymond Rao. I'm not sure if the best AVM which is best for surgery is the best for radiosurgery. See, an AVM which is in a non-eloquent region, which is bled, compact, specimen grade 1 or 2, the first option is surgery. Usually in radiosurgery, wherever we treat, the lesions which are in the center of the brain are more amenable for radiosurgery than they are on the surface. Suppose you have a frontal AVM or a temporal AVM which is in the lateral or near the convexity, they are actually better to undergo surgery than radiosurgery. Now with the mask-based treatments coming up, CyberKnife and Zap-X, it is easier. However, when we were doing radiosurgery, gamma knife, it's only frames. This as a principle, lesions which are close to the skull are always difficult to treat with the frame-based treatment because you will have issues in treatment because of collision, and also by radiosurgical principle, as well as MR acquisitions, the resolution and accuracy is more in the center, and as you go more and more to the lateral part of the brain, the resolution comes down and the treatment efficacy also comes down. So we used to have problems when there is a lesion, whether it's a AVM or a tumor in the convexity, frontal, occipital, or temporal, because of these difficulties. One is due to collision as well as the dose homogeneity. Therefore, an AVM which is in a non-eloquent cortex in the polar region or in the surface, small, compact, is a very good indication for surgery, more so if it has bled. Whereas an AVM which is in the central part of the brain, if there is a caudate lesion, AVM in the caudate or thalamus or in the deep white matter, that is a better indication for radiosurgery than surgery. So it's not that an AVM which is best suited for surgery is best suited for radiosurgery. That can only apply when it's a compact AVM, because the planning and marking of the lesion will be easier when it's a compact AVM. However, if it is in the depth, then radiosurgery is a better option than surgery. Coming to the second point of embolization, we'll discuss further over that. Earlier we used to embolize AVMs to reduce the size, because again there was an issue of giving the dose. The issue of size comes into view not just the lesion, because of lesion, but more because of the radiation received by the surrounding normal tissue. So the larger the size of the lesion, more dose is going to be delivered to the surrounding. So there was always a restriction. But now with both volume fractionation as well as dose fractionation, we are able to overcome that. We are treating AVMs which are more than 10 cc, many often. So in our setting at least, the incidence of embolization for AVM and then bringing down the size and then going for radiosurgery has come down. Mainly because there are literature as well as paper from our own center where we have shown the efficacy of radiosurgery for an AVM versus efficacy of radiosurgery for an embolized AVM. If you compare, the embolized AVMs actually respond worse to radiosurgery when compared to a virgin or a primary de novo AVMs. Mainly for two reasons. One, because the embolization is never sectoral. If you take a AVM as a sphere, you can't just say I embolized a part of it and remaining everything is. The embolization is always patchy. So there are always areas of nidae between the embolized region, so you'll have to cover more. And second, how the radiation will go through and how this material, the glue or onyx material that goes into the AVM, how it will cause variation in the radiosurgical dose is not clear. So in our experience as well as literature, embolized or partially embolized AVM actually have a poor radiosurgical control. So we do not prefer, earlier we used to do to reduce the size, now we practice dose fractionation, some centers do volume fractionation. So we try to do radiosurgery upfront even if the AVM is large. Now coming to your question about, I think I answered your question.
Yes, you know.
If there is an AVM which is in the motor, forget about motor cortex. If there is an AVM in an eloquent cortex, small, compact, again we always tell every patient all these three options: surgery, radiation, embolization. Radiosurgery among the three is better choice, but I would like to put a note of caution here. I am just only telling it's a better choice. It does not mean it is a choice without risks. If there is a lesion in a eloquent cortex, whether you surgically remove or you give radiation, there will always be attendant risks because the procedure or the treatment is going to cause damage to the AVM as well as some edema or some damage to the surrounding structure. Except the fact that if you operate, you will find the deficit tomorrow, whereas when you do radiosurgery, you will find it after a few months. So it is not without risks. The probability of developing a deficit is far less with radiosurgery than compared to microsurgery.
Yes, please.
You asked about eloquent cortex. Arivalgan made a very nice point about compact AVMs. To cite an example, I had a 19-year-old boy who presented with seizures, and he had a left temporal AVM situated in front of the language area as shown by the fMRI. And we counseled everything, giving anticonvulsant drugs, subjecting him for radiation and surgery. The parents were highly educated and they didn't want to take the option of not doing anything and just waiting for some problem to crop up later. Radiosurgery, they looked at this. I had operated some 8 years back. So they looked at several literature and decided against radiosurgery because of the problems of young age and problems of oncogenesis, etc., which they had come across. So finally we decided upon surgery. The favorable factor here was a sulcus was separating, the sulcus with its CSF was separating the AVM from the language area situated just behind it. So we did an avicraniotomy and removed it, and without causing a deficit. So it's possible to operate on so-called eloquent areas if there is a clear demarcation and what point he said if it's a very focal compact AVM.
Thank you, sir. Just for paucity of time, this will be the last question. Sir, my question to you again is dealing with AVMs in pregnancy. Small AVMs, incidental finding in pregnancy, or people who have bled during pregnancy. When do you want to do a radiosurgery? Is it safe? What is the timing? When can it be done? Or if incidentally it is found out that the person has an AVM, would you want to leave till the patient delivers? How do you go about this?
Incidental AVM? Or
During pregnancy, yes, sir. During pregnancy, we've had cases wherein we've had postpartum and 6 months, 7 months pregnancy patients who've come to us with A, incidentally found out to have headaches, and B, also with bleeds. So in both cases, if it's a small minimal AVM, do you like to wait in a incidental finding, or do you want to go ahead and?
Incidental AVM, absolutely asymptomatic in pregnancy, I would like to wait. If it has bled, then there is a problem because the chances of rebleed is there, and during delivery also, normal delivery would be extremely difficult in a situation like this. So that AVM would require treatment. There are various ways of treating. If it's a small AVM with a single feeder, it's possible to embolize it during surgery. Again, the risk of radiation to the fetus is always there when you use embolization. With adequate shielding nowadays, it should be possible. I wouldn't advocate radiosurgery for an AVM which has bled.
Right. Thank you. Any questions from the audience, please?
One question related to the vascular malformations, not directly brain AVMs, to the panelists as well as to Professor Adler and other radiotherapists. about vertebral hemangiomas. Symptomatic, solitary, would you like to do today SRT? And asymptomatic, but increasing on size for various reasons if the spine MRI is done. Any role of...
we don't have experience of spinal RT in our setup, I think.
Professor Adel?
Hemangiomas or?
Hemangiomas of the vertebral bodies.
Yeah, I have an experience of treating all one, and it did brilliantly. So it was a lumbar vertebral hemangioma for whom chronic pain was a problem, and literally within weeks of being treated with the CyberKnife years ago, pain all relented. Now, there are other treatments for spinal hemangiomas, and there are ethanol injections and other things. So I think radiosurgery is one more thing to consider. So I would give it a shout out for my limited experience.
Thank you.
Thank you, sir. Thank you for your esteemed presence.
Thank you all the chairpersons and panelists. I now request Mr. P. Shiv Kumar, Managing Director, Indraprastha Apollo Hospitals, to please felicitate the panelists. Ladies and gentlemen, esteemed guests, it is an absolute privilege to stand before you today and introduce a true visionary in the realm of medical innovation. Our distinguished guest needs no extensive introduction, for his name is synonymous with groundbreaking advancements in the field of healthcare. Today, we are honored to have in our midst none other than Professor John Adler, the brilliant mind behind the revolutionary medical technology, the Zap-X. Zap is the result of Professor Adler's ingenuity and stands as a testament to his dedication to excellence in healthcare. This cutting-edge technology has defined the way we approach precision medicine, providing solutions that were once deemed elusive. Ladies and gentlemen, the Professor John Adler. Professor John Adler is a Professor Emeritus Dorothy T.K. Chan, Stanford University. He is the founder, CEO of Zap Surgicals and Curious. Professor Adler will be talking about recent advancements in stereotactic radiosurgery. This session will be chaired by Dr. Siddharth Ghosh, Senior Consultant Neurosurgery, Apollo Vanagram, Dr. Sudhir Kumar Tyagi, Senior Consultant Neurosurgery, Indraprastha Apollo Delhi, and Dr. Ramana Murthy, Senior Consultant Neurosurgery at Apollo Specialty Hospitals, Nellore. May I request the chairpersons to please come on the dais? I would now request the chairpersons to please invite Professor Adler for his talk.
It's my honor and privilege to call upon Professor John Adler to the dais. I'll just give a I'd like to give a small anecdote here. Way back, I think in 2006 when this first CyberKnife came to our Apollo. And know that it was installed and Professor Adler was there. And they were looking for somebody whom they can give CyberKnife. And it happened to my own brother-in-law who was having severe trigeminal neuralgia. He was from Bangalore and he never wanted surgery, as we were discussing. So I asked Professor Adler whether he could have his first case in the CyberKnife on him, and he drew the target and he gave it, and now almost last more than 20 years, he's totally pain-free.
Happy to hear. Thank you. Thank you. It's the best introduction I possibly could have, so thank you. Again, a unique honor to be here today in this circumstance. Unique honor to have my child be here in the Apollo system. I've been, Dr. Reddy and Apollo have been so kind to me through much of my professional career. And it's probably not an accident that this is where the ZAP is beginning its journey in India at this time. So I've been given the task of talking about radiosurgery, perhaps going forward. Will my slides go up, or can I ask for my slides to appear? And with a prayer, some of the videos will even work. So the impetus for this is really going to follow up on Dr. Prahl's initial presentation about how the Zap-X works, because that is what's next in radiosurgery. But I'm going to use that to branch off into where I think technologies will evolve. And then I want to very much focus, and I think what's going to be one of the great frontiers in medicine over the next few decades in the world of neuromodulation, and what I'm referring to not as lesion-based, but radiomodulation, which I'll explain as we go forward. So I've been in love with radiosurgery since that time in which I had lots of hair in my head. During those days, coming from Harvard, I thought I was educated, thought I understood neurosurgery. And yet, when I fell quickly under the spell of Lars Lexell, who you see on the left putting a patient in the Gamma Knife, I realized that there was a whole new world of medicine emerging. And from the minute I was introduced, I wanted in. I wanted to be part of what I thought would be a type of therapy that wouldn't just last for decades, would literally last for centuries. Now, since those days, radiosurgery has hardly been undiscovered. This is data from America, but I'm sure it applies to much of the world. But you can see over the last 30 years, radiosurgery went from an afterthought, what neurosurgeons did, to what dominates what neurosurgeons do today for brain tumor. So this is just for brain tumor. You can see today in America, and there's some statistical noise in here because there's billing nonsense, but strip out the billing nonsense and what you'll see is that over 30 years, radiosurgery has come to dominate what neurosurgeons do for brain tumor. For every open operation neurosurgeons do for brain tumor, they're doing 1.5 radiosurgical procedures. And yet, that's not enough. We do a bottoms-up analysis looking at what radiosurgery could do today, especially where it's done, how it is practiced in some of the most advanced settings. And we believe by the end of this decade, in the world, we should be treating as many as 5, if not more, million patients each year with brain and head and neck radiosurgery. Let that soak in. 5 million patients each year potentially treated with radiosurgery. Many of them are in India. And yet today in the world, we're treating only 200,000 patients. So this best-in-class treatment, and radiosurgery in many circumstances clearly is the best in class, and also reasonably affordable, yet is reaching less than 10% of the patients who would benefit. To me, that's a problem. It's also an opportunity. It's kind of how entrepreneurs think. And so it became someone who'd given his life to radiosurgery, realizing that it's so underutilized. I decided it was kind of an opportunity, but also a duty to remedy that. And that became the impetus for the Zap-X. Now, I'm not alone in understanding that there's a shortage of radiosurgical instrumentation in the world today. There's academic peer-reviewed articles, and there's probably more than a dozen that have shown that patients are not being treated with radiosurgery today because of primarily a lack of facilities and also lack of training. Now, many of you take for granted radiosurgery, but you have to step back for a second and understand that radiosurgery is the most expensive and complex procedure in all of medicine today, short of protons. And I know Apollo is invested in protons, God bless you, but short of protons, radiosurgery is almost an insane type of medicine. It's expensive and complex. Big teams of doctors need to work together. Special shielding, you have to work with cobalt, all kinds of regulations. But in the end, what it means is 9 out of 10 patients today, and if you go to probably sub-Saharan Africa, it's much more, 9 out of 10 patients are not getting radiosurgery. So that was then. As we like to say at Zap, this is next. So I'm finishing up my tour of duty at Accuray, going back to Stanford, I started to imagine what might be next. Eventually focusing on the brain, head, neck, and took a clean sheet of paper to the problem of radiosurgery. How might we do better? How did the CyberKnife and Gamma Knife and linear accelerators, how did they fail to address the problem today? And in this process, it was of ideation, joyous process, came up with literally hundreds of different ideas, concepts for what a next generation radiosurgery device might look like. Took a lot of work looking at these things mathematically, looking at them structurally, looking at them with various CAD drawings, and also looking at them financially. And in the end, this is what we came up with, the Zap-X, which we're kind of celebrating the last couple of days. And we're going to talk a little bit about what makes it special. It is not a radiotherapy machine, it is a radiosurgical robot, a surgical robot, very much to be utilized by surgeons in conjunction with radiation oncology to drive the frontiers of radiosurgery and therapy in general. Now, radiotherapeutic radiation has been around 100 years or more. Marie Curie, God bless her, kind of created this magic of medical therapy. And yet for this 100 years, to safely perform radiotherapy, it's always required radiotherapy vaults. So one of the accomplishments we set forth was to get rid of the radiotherapy vault. They're expensive, they're complex, and they can only be generally located in certain basements of big hospitals. But once you get rid of the vault, you can start thinking about how to put radiosurgery directly in the hands of surgeons and doctors who treat patients. Make it that much more available in the world. You don't necessarily have to be in the biggest hospitals of the world. And here are examples of why radiosurgery can be front and center and visible, as you now have shown here at Apollo. This miracle of medicine, and we'll give Apollo a shout, yes. Arsha, you're a good promoter. You're following the footsteps of your grandfather. But radiosurgery has been this miracle. I mean, how many procedures in this world can you have a life-threatening condition, have a 30 minute to an hour painless outpatient procedure, go home cured, and often at great cost? Radiosurgery is a miracle, and yet the world knows next to nothing about it. In this new world, as shown here at Apollo, radiosurgery can be very visible. It's part of the therapeutic armamentarium we doctors have. As mentioned before, cobalt-60 is bad, bad, bad stuff. Now it's been powerful for Gamma Knife. The Gamma Knife has pioneered radiosurgery. But the world does not need cobalt-60. Gets in the wrong hands, kids can be injured, die. It has happened in Brazil. But even more scary, could it get in the hands of really bad people, terrorists, and do horrific things, making a dirty bomb? So we don't want cobalt-60, we don't need it. So that was one of the primary design specifications here. And when you use a linear accelerator, you can make it even higher output. Don't need to worry about degrading over time. When it does degrade, you change your BED, and who knows what that even means. By starting with a clean sheet of paper, all the key variables for radiosurgery could be optimized. And they're pretty self-evident, but they're worth reminding many of the room who may not have had to think about it. In the end, we want the sharpest knife, the sharpest scalpel. We use the steepest dose gradient. And what gives you the steepest dose gradient? Well, the more directions of crossfire. The more directions you shoot the beam at and concentrate at the point of intersection, the steeper the dose gradient. So we can optimize that. Moreover, the beam energy. The CyberKnife I created was a wonderful tool for treating everything, but the energy was really designed for prostate cancer and intra-abdominal and lung cancer. You compromise for the brain, but in this case, making a dedicated robot, it's optimized for the brain and head and neck. 3MV Linac. Moreover, we can make a new generation collimator that blocks almost all the scatter. Really, an order of magnitude better than anything that exists today. In some cases, even almost 2 orders. And lastly, we were able to optimize the distances. Because we're not treating prostate, not treating lung, and that gives us less penumbra. All these things together in aggregate give you a better tool, a sharper dose gradient. Moreover, by designing what we did, we limited the radiation scatter that goes to the whole body, which is something the Gamma Knife also accomplished, but literally was order of magnitudes better than variant like Linacs and CyberKnives. We don't need to worry anymore about treating benign condition in young people because the dose of whole body radiation is so little. And this also, of course, opens up the treatment of children, which is increasingly being done with the Zap-X, which has anesthesia ports in and out to allow both general anesthesia and the necessary monitoring. Now, we've already kind of seen this video, and I'm going to speak over it this time because I want to talk about the key variables. Oh, we don't need that. Whatever. Site. I'm a Mac user. Just get me back in, and we don't need all. Well, we have to put up with the music this time. What I want to focus on is that this unshielded environment gives a general public dose of radiation to the operator who sits right next to the machine. That operator doesn't even need to necessarily be badged, radiation badged. Now, the patient does go entirely in this machine, but it opens up inside, has actually a couple windows looking in and out. It is not claustrophobic. The collimator, 800 pounds of tungsten, does a better job of blocking scatter radiation than any collimation system ever created before. And we can change the size of the beam that we're using literally in a second or two by spinning this disc. A whole new degree of flexibility to ensure that you're always delivering the steepest dose gradient. The targeting is this image-to-image correlation that underlie the CyberKnife. Real time, you acquire images and you correlate them against digitally reconstructed radiographs. And that correlation process that takes a couple seconds can establish sub-millimeter targeting accuracy repeatedly throughout the procedure. Now, this device is a robot. The table has 3 degrees of freedom. The purpose of the table is to get the target, let's say the tumor, at the point of isocentric rotation. And it does that with 50 micron accuracy. Now, there's 2 great degrees of rotation. Your axial, like a variant device, but then you have an oblique. And these 2 degrees are independent of one another, and they give you all the various different angles of crossfire. More crossfire equals a steeper dose gradient, equals a sharper knife, equals a safer knife. And we're not even done. You're going to see more and more angles going forward. Even better dosimetry going forward. Today, this is point and shoot. One direction, point, aim, shoot, point, change, retarget, point, shoot. But the device lends itself to dynamic arcs, and that's where we're headed. We're going to take what are already the fastest times and cut them by another doubling or tripling faster, 3 times faster. And lastly, we have the first time real checking device. You know, in the past, radiosurgery always required perfect physicists, but if you screwed up because you hurt or killed patients, and this has happened in more than 1,000 instances, patients died. And literally hundreds of millions of dollars of settlements have been paid out because of these screw-ups. But it'll never happen again with this new online verification tool. And so this is what new radiosurgical centers are looking like. They're front and center. They're going to become increasingly, I hope, the face of modern medicine. So we keep talking about dosimetry. Okay. Maybe you want me to shut up. Is that the key? But in aggregate, all these things give you this steep dose gradient that Dr. Prahl talked about earlier. And this is already 3 years old data from Phoenix. We now have curves that are much better than this. And they're going to be even better again before the end of this year. The treatment planning, we've taken a whole new approach to. In fact, what you see here is all going to disappear in the next 2-3 months. We've tried to make this new generation of treatment planning more intuitive. We feel every doctor should be capable of doing treatment planning on their own patients. And I predict in about 10 years' time, treatment planning will be almost fully automated, maybe generating no more than a single click, as we use increasingly AI tools, machine learning tools, mining the experience of literally decades of radiosurgery, and all the patients we treat now with Zap-X contribute to this new generation database and ever better treatment plans. Now, what does this mean? It means, in the end, the best possible dosimetry. Ian Paddock, the leading force of gamma knife radiosurgery in the world today from a physics standpoint, was asked in the NHS to look at the different types of radiosurgery platforms that the NHS had. And look at them, which are good enough and which should be thrown out, discarded. And he did a treatment planning study looking at, well, there must be about 70 or 80 centers in the UK. And what they found was, on average, and they plotted something called the R50%, and I don't want to go into this, but it's a way of measuring how well the dose conformed and restricted just to the target and how little was given to the rest of the brain, even with irregular shaped targets. And what they found was that the gamma knife was the best. He's a gamma knife guy, not a big surprise, but I'm not surprised given the basic physics of cobalt-60. He found next the cyber knife was these little blue triangles. It was not as good as the gamma knife, but okay. And then we have a range of different linear accelerator technologies. Well, this was a big study published by the NHS, and they just changed the whole NHS policy based on this. They then took this same data set and we plotted it with the Zap-X treatment planning system, which is these little red circles at the bottom. The Zap-X was the best of the best, and this is 3 years ago before we've implemented a much better treatment planning system that's rolled out now. So the best of the best and getting better, that's what you have here. Whether it be trigeminal neuralgia, minimal dose to the brainstem, and again, getting better. Multiple brain metastases and getting better. The goal is, by the next 18 months, to be able to treat 20 brain metastases in less than an hour on the Zap-X. So the idea of letting brain metastasis number be a limiting deciding point on whether you revert to whole brain radiotherapy, we open up new vistas. Only if a patient's going to have 100 brain mets do you really have to give up. Because even patients with large numbers of brain mets, we sometimes find, because of better systemic therapy, will live years. But what's the sense of living years demented if it doesn't have to be that way? So this is all getting started. You're part of this new revolution now in Apollo. We've got about a half dozen different published outcome studies that show, on average, the outcome is quite comparable from the Zap-X with what exists today with the gamma knife and cyber knife. But people are starting to hone in on some of the unique attributes of the Zap-X. And I think in time, in cases like tremor ablation of the thalamus, VIM lesioning, trigeminal neuralgia, acoustic neuroma, sparing the cochlea, the treatment of para-optic nerve tumors, you will start seeing how you have superior outcomes with a sharper knife, a steeper dose gradient. So here's some early results. Here is a trigeminal schwannoma treated a few years ago. You see over the course of 9 months, loss of central contrast enhancement and shrinkage. Routine outcomes, but still nice to document with the Zap-X. So who are we? Where am I? I'm a Silicon Valley guy, Stanford guy. So is the company, just next to San Francisco Airport. And if any of you are ever transiting through San Francisco Airport, please come pay us a visit. And this is a startup funded by the Foxconn Corporation. The product is now regulatory cleared in much of the world. And most importantly, just in the last several weeks, right here in India. And we're excited to now be really a product of the world, because that is really where the patients are. The objective here is not to ignore the global south. The global south has literally billions of people who deserve world-class healthcare, and we believe the Zap can do that, and certainly we're starting that here in India with Apollo, and we're so grateful for giving us that chance. So how radical can you be? Well, here we have a radiosurgical facility in a bullet train station in Tokyo. Patients bullet train in, they bullet train out, and literally millions of people each year go by in the train watching world-class brain surgery happening. This is the face of brain surgery, modern brain surgery, which of course embodied now in Apollo. So we have centers around the world, and soon I have to add Apollo to this list here. We have this list here, 23 machines will be operational here by the end of this quarter, and another 40 waiting to be shipped and installed. And in fact, the backlog is growing. At the moment, we're selling faster we can deliver. But where's this headed? What are we trying to accomplish other than be the best? How are we going to do that? Well, we're starting with ever better treatment planning system. And that is going to be rolled out. It's already in the customer's hands, a beta version right now. It allows much faster algorithms, much better dose conformality, and faster treatments. Fast last year, faster now, and even faster next year. We have a whole series of new tables and head fixtures that lead to less movement once the patient is in the mask, and also allow full range of motion to the bottom of the neck to the top of the head. And in Munich, they started treating ocular melanoma just a few months ago. So that's going to be very important. Ocular melanoma is a very interesting target. In the past, protons largely dominated that space. Now, you can do it with photons in the Zap-X. For those who can't give up their stereotactic frame in the Gamma Knife world, if you still believe you need pins, well, we now have a stereotactic immobilizer. Not a frame, we don't do frames, but we now have a pin fixation device that will make sure the patient doesn't move at all while delivering treatment. We're designing ever faster treatment paths, also ever more conformal. And we'll be going to arc-based treatments, shooting for 20 brain metastases in less than an hour. We've just introduced a new collimation system for functional treatments. Only 3 millimeter diameter. And we may be even going smaller, and I'm going to show you in the next few slides why that's so important. We're going to faster gantry rotation someday. Right now we're limited by IEC rules that say you should only move at 1 RPM, but this machine is capable of going to 4 and maybe even 8 RPMs. You can anticipate, I think in the next 5 years, treating 20 brain metastases in 10 minutes, 20 minutes. The world is really moving fast, and Zap-X plans to be part of that. And lastly, we want to even show that you've hit the target. Not only do you deliver the dose, but you hit the target with our MV imager. Radiosurgery is going to give you all the feedback that you as a surgeon have always experienced when you're doing live open surgery. Are you hitting the target? Are you hitting it to the right depth? We want radiosurgery to emulate what you do in the operating room. But what I think is going to maybe the single biggest revolution, maybe in all of healthcare in the next few decades, is in the world of neuromodulation. And there's some poetic justice here. That's why Lexell invented the Gamma Knife. Lexell did not invent the Gamma Knife to treat tumors. In fact, you could hardly visualize tumors when he conceived of radiosurgery in the 1950s, 1960s. It wasn't until the 70s that we had CT. But in the early days of the Gamma Knife, it was about making lesions non-invasive in the brain to treat movement disorders, to treat psychiatric disorders, chronic pain. But one of the very important messages Lexell gave us, which is what we're about to disprove, is he said no lesion equals no effect. The only way you could change brain function in Lexell's universe was to make a hole in the brain, make a lesion. However, those of us who have been doing radiosurgery now for decades know that maybe that's not entirely true. Those of us who've done trigeminal neuralgia treatments, sometimes a patient will get off the table, never have pain ever again. Something cannot be explained by a lesion. Lesions don't happen instantaneously. But there's some kind of phenomena in which radiation changes the activity of the trigeminal nerve when treated that way. That observation has been somewhat replicated now with a cardiac ablation treatment for cardiac arrhythmias. When you treat these patients with cardiac arrhythmias, they get better almost instantaneously. It's not a lesion. Well, meanwhile, we now know that the biggest diseases in the world today are not the tumors and AVMs or trigeminal neuralgia, the things we talked about. Those diseases are relatively inconsequential when it comes to the disease burden that humankind faces. In fact, the biggest diseases in the world today are these: the functional disorders that afflict people in all countries, all nations, especially in America. Things like chronic pain, things like depression, things like addiction. And neurosurgeons have not been blind to that. Neurosurgeons are gradually and slowly taking the tools that we've developed over decades and starting to turn things like DBS and starting to see how they might change brain circuit function in these diseases with the tools we have. Because in the end, these are not diseases of the brain. They're diseases of brain circuits. And we know that the drugs to change these brain circuits, their function, their capabilities, have plateaued decades ago. So it's up to us neurosurgeons to figure out, do we now have procedures to treat this next generation? Well, this is what some people are contemplating. So my protege chairman at UCSF, Eddie Chang, he is now doing some brilliant work, getting lots of attention. He can show that with enough brain recording, he thinks that he can now treat every patient with intractable depression, and requiring, though in many cases, multiple electrodes at multiple different nodes in the depression circuit that he teases out in each patient. Brilliant that we can think about treating everybody with depression. Yet it's kind of incomprehensible that we're ever going to do something like this for a disease that afflicts tens of millions, if not hundreds of millions of people. We're not going to put in a dozen electrodes. But taking the phenomena that I observed in the trigeminal neuralgia, we've observed a little with epilepsy in the brain. We treated with hypothalamic hamartoma. There's something that goes on sometimes in the brain after radiosurgery that changes the local activity. And so I wanted to go back to first principles. What is that? What is it you're doing to the brain or the heart? What I refer to as radiomodulation. So here's some work that we did in some pigs. This particular study is done in Taiwan, National Taiwan University. What we did is we treated a very small region of the pig M1 motor cortex. Then we imaged it, PET, FDG PET being a correlate of local circuit activity. Very effective, very reflects the neurons firing or not. And then we studied these pigs very, very carefully, little over 2 years. These are laborious experiments, bringing the pigs back every 3-4 months to get a new MRI scan, a new PET scan, all under general anesthesia, moving them between the farm and the hospital, Incredible lot of work. Thank God it was affordable in Taiwan. But what we see in this slide is ultra heretical. I want you to notice that we had some doses between 10 and 40 gray. Let me see if I can work this. What's that? Can I get my slides up? What we have here is a level of PET activity. This is the baseline level right here. And you can see when we treated at doses 10 to 40 gray, what we got is we didn't get inhibition. We got disinhibition, activation of the local brain circuit. And then at larger doses, 50, 60 gray, we did get inhibition, perhaps in anticipation of what Lexell would teach. And then at these very large doses, you got cell injury and death, which is what Lexell taught us years ago. So we've known that you can make injury to the brain with radiation, but we never knew that you could actually disinhibit. You could activate and then inhibit. This is almost unanticipated. Moreover, we looked at the same kind of question, asked the same kind of question, but studied it in a very different experimental setup. This time in Germany, or in Denmark, at a University of, this is Aarhus University in Denmark, and also the University of Mainz. And this time what we did is we're looking at visual cortex. We're trading same way with a very small volume radiation to the visual cortex of the pig, these mini pigs. They grow to about 40, 50 kilos. And we then looked at the dose escalation study, and after we did the treatment, 6 months later we implanted electrode grids to see what was happening at the area of treatment. And we studied this area of implant with visual evoked potentials and spontaneous EEG. And what we saw is, again, consistent with what I showed you in the pigs in Taiwan. We saw with these lower doses, up to 40 gray, we saw disinhibition, activation of the local circuit that endured, again, up to 2 years, at which time these pigs were sacrificed. And at these lower doses, up to 70, 80 gray, we did not see any lesion. So what I'm defining is a new field of biology, new field of radiobiology that's been unrecognized previously. Maybe we saw some clinical anecdotes about it, but what we find here in aggregate, this is all the data together, is that baseline neuronal circuit activity, when treated with low doses of radiation, up to 40 gray, actually increases activity, disinhibits, and endures for 2 years. And at greater levels of dose, you get inhibition, and only at the highest doses do you get injury and death. So this is a new chronic, durable construct to treat, alter brain function. And where are we going to start? Well, we're starting in some pigs. We're back in Taiwan now. Here we have some pigs that are exposed to alcohol, induced to drink at first by sweetening it and put some sugar water in it, cider actually. And what you find is that these pigs, once becoming alcoholic, they give up all the things that pigs like to do. They're no longer interested in food, water, toys, even sex. All they want to do is they want to go back to that pan with the alcohol. See that pig? He's had too much to drink. He's an alcoholic. He goes over to the pan, he drinks more alcohol. There's a little button. He pushes his nose against the button 4, 5, 7, 8, 10,000 times a day to get alcohol in that pan. And we can make it harder and harder and harder to get alcohol. But they're typical addicts, they're typical alcoholics. They spend their life pushing that button to get more alcohol and giving up all the normal things that pigs do. They are addicts. And we've taken these pigs now, a handful of them, and this is what we've been able to do. This is their baseline alcohol consumption before treatment. This is the time of treatment. And you can see when we treat their nucleus accumbens with a neuromodulatory, radiomodulatory dose, in this case between 25 to 30 gray, we get marked near instantaneous decrease in alcohol consumption. And it endures. And there's no lesion. So this is where we think radiosurgery is going. Particularly the target we're first going after in human alcoholics is this shell of the nucleus accumbens, this red structure there. And this structure is right next to the hypothalamus, right next to the visual pathways. There's no room for compromise, no room for error. And the beauty of the Zap-X is it's uniquely designed specially designed for these kind of very small, delicate targets. So I showed you before where Dr. Paul showed you this series of graphs and how the Zap-X was the best of the best. Well, now we've taken yet a new measure of new collimation. And you can see what was once what we existed. The curve up here that there was the Zap-X is now this outer curve, and we now have a new curve with a new collimator. So steeper dose gradient, getting steeper and steeper, making it possible to go where no treatment has gone before. So this is what much of the world thinks is adequate radiosurgery. Much of the world uses a general purpose radiotherapy machine and tries to do radiosurgery. In fact, Varian gives me credit for inventing their Edge machine. But it's nothing but a compromise. It's a compromise to treat breast cancer, brain cancer, kidney cancer, prostate, and do a little radiosurgery on the side. But the brain is too important to just compromise. For the brain, we should have only the best tools. As my mentor Lars Lexell said, when it comes to the brain, your tools cannot be too refined. So in the end, where is radiosurgery going? This is Star Trek, maybe some of you remember. But what was predicted by Gene Roddenberry is that 200 years from now, we're going to be using something that looks a lot like a gamma knife helmet. Why? Because I think the principles of radiosurgery are going to endure. The tools will change. I'd like to think the Zap-X maybe the next century, I don't know. But the tools will change, but the principle, I think, are going to be present for years and centuries to come. Where else do you have a procedure that's no pain, fast, outpatient, highly effective, very little risk compared to almost all surgical procedures? And yet, we're not done. It's getting better, as I showed you with the Zap-X, getting better and better and better, perhaps as we explore new energy sources in the future. And lastly, I think there's great opportunities for synergies with drugs. And perhaps here in India, where you have this burgeoning pharmaceutical industry, it's a great place to explore these synergies to make ever better treatments. So this is the present and the future of radiosurgery. And this future is very much at home here in Apollo. So with that, I want to thank you for giving me the privilege of speaking, and thank you for being here.
Thank you very much for such an enlightening talk and covering almost everything about the radiosurgery, starting from the history and to the newer indications. I still feel, where does the role of proton beam comes when you say everything can be done on Zap-X?
Where's the role for protons?
Yeah.
I mean, there's a theoretical role because the scatter radiation to the rest of the body is clearly lower than protons. While the Zap-X is the best of photons, protons you can do better. So in children where you want not to irradiate children needlessly, and of course they have pediatric brain tumors are quite common. I think you can make an argument that that's a good option. But unfortunately, most proton treatments today are now busy treating breast cancer and prostate cancer. And I guess if people want to do it, it's a free country. But I think that largely in the brain, almost everything can be well done, almost perfectly done with photons and getting better. And getting better. That's the take-home message, and getting better.
I'm Dr. Murthy from Andhra Pradesh, India. Happy to witness the launch of Zap-X in India. Happy to witness your decades of hard work, the joy with which you're launching Zap-X in India. I'm really happy, sir. I have 3 questions, if you permit. How does the metallic implants of cranioplasty, like thick titanium sheets, interfere with the treatment in this Zap-X?
So obviously, if you have metal in the head, you're going to change the dosimetry. But you know, most of the metal, for example, we use in cranioplasty right now is titanium, and I mean, I suspect, maybe there's a smart physicist in the room and they can come do a quick calculation for me, but I suspect that the deviation from plan is going to be less than 1 or 2%. So I don't think it's meaningful. For the most part, we don't even know what dose to give to probably to the closest 20%. So I think it's not any reason to worry in the least. But keep in the back of your brain, and someday maybe there will be something I'm missing right now, and it will have an impact. But right now, I would say don't worry about cranioplasties being present or not.
We all agree the burden of head injury in India is very high. The usage of cranioplasty material is also very high in India, following a decompressive craniotomy. That's why I asked this.
And what kind of cranioplastic material are you using?
We regularly now use titanium, thick titanium.
Titanium, okay. But titanium is pretty transparent to most energy of X-rays. So.
My second question, sir. In a reproductive age group female patients who underwent Zap-X treatment, how will be the future reproductive process? The childbearing, the problems with childbearing and all?
I'm not sure I understand the question.
In a young lady who underwent treatment under the Zap-X machine, what happens to her ability of reproduction, and what are the chances of having
a child? Reproductive. Okay. Well, I do know that the Zap-X gives less scatter radiation to the rest of the body than you can with any other technology, but you're absolutely right. I mean, your radiation in the developing brain is incredibly hazardous. And certainly, if a woman was pregnant, I would not recommend she ever be exposed to any radiation. But is there a circumstance where that still might be okay? I mean, we all have to make difficult decisions sometimes, and perhaps and to save the life of a woman, it might make sense, but it does come with great risk, as you just suggested.
Last question. Can you enumerate the tumor size? At which tumor size you go for surgery? For example, meningioma or a GBM? At which, the size of the tumor at which you decide to go for a Zap-X or go for a surgery?
Well, all this is customized, needs to be. You are absolutely right that large tumors are still best treated for the most part with open surgery. We as surgeons can do a very efficient job of getting rid of large tumors with minimal risk to the rest of the brain. Yet, even with large tumors, there's oftentimes an attachment point in eloquent cortex or the skull base or in and around cranial nerves where there's still a combination approach is better and safer. So while open surgery is good at debulking the mass of the tumor, radiosurgery will always be best for destroying that last bit of tumor in and around critical anatomy. And so in between you have all kinds of gradations. So there's certain circumstances where all open surgery makes sense. There's certain circumstances where all radiosurgery makes sense. But what you can see is that year in and year out, more and more cases seem to be falling into the realm of radiosurgery because our techniques get better, the facilities become more available. And so I believe that it's a moving target. So today, a target 3.5, 4 centimeters, you almost always start pushing more and more for open surgery. Maybe with drugs, maybe with better radiosurgery in the future, some might come back in 10 years and say the dividing line is 5 centimeters. So keep up, pay attention, and together we'll figure out what the dividing line is. Thank you.
Dr. Sugani has some questions.
Yeah. The tumors which are on the base of the skull, it is coming down to the foramina magnum and upper part of cervical spine. As you say, it will work for head and neck. So up to which level in the neck we can give the treatment by Zap-X?
It's designed to go to the base of the cervical spine, C7, in the 95% American male. So, okay, you have to just pick a number. And so since the 95% American male is pretty damn big, chances are in much of the world you can get 99% of the population you can treat to the base of the neck. And so we would like to start seeing some primary head and neck cancers treated with the Zap-X. Yes, sir. Spine radiosurgery? Well,
What is the future?
Well, the Zap-X intends to be very much part of the cervical spine of radiosurgery, and I believe there's a great role for whether it's metastatic disease or primary tumors or schwannomas or interest of mine has always been spinal cord AVM. So if any of those lesions exist in the spine, they can all be treated with radiosurgery, and if they're in the cervical spine, they can all be treated with the Zap-X radiosurgical system. Now, if it's in the lumbar spine, go find a CyberKnife. That would be my suggestion, because the CyberKnife is still a very good tool for the rest of the spine. What? Why not? Dr. Reddy did. So I mean, look, if you're a neurosurgeon, you don't really necessarily want a CyberKnife because you don't need to treat prostate cancer and breast cancer. I mean, you want to have the best possible tool for your neurosurgical patients. And you too, if you're the patient, don't you want the best tool on your brain? Of course you do. So the Zap-X is there to be the best. Now, if you're one little hospital and you're, in a small little village in the middle of the foothills of the Himalayan mountains, and a place I've never been, but it's in my brain, I can imagine it, then maybe you have only one radiation machine. Maybe you just get a varying machine. Okay? Maybe. But if you are in a community that wants the best possible care, and it's a good-sized community, you're going to want to have the best tools, and the Zap-X will be your best tool for the brain. Interaxial brainstem?
Yep.
Are you talking about primary glioma, or are you talking
Primary gliomas.
Well, I understand, I've never treated a Zap-X case myself, okay? But I've done a handful of those kind of procedures in my former days at the CyberKnife, and there's a real role for it. Now, I don't believe there's much of a role for diffuse infiltrating juvenile malignant tumors. Now, but where you have isolated tumors, and they can be causing symptoms, whether they be a facial palsy or facial pain. Radiosurgery is a great procedure, and I believe in time the Zap-X can be as good, if not better, than any other technology there. But that's not a common tumor. That's a relatively unusual tumor. And Max Ruge, he may want to even talk about it because he has a little bit of a specialty practice in treating brainstem glioma.
What about the lesions in the vortex of the brain? Can Zap-X treat them?
What about them? Yeah, there's all prime targets for Zap-X. From the vertex to the bottom of C7. If you have a Zap-X, you can treat them all.
Sir, there was a previous question about foramen magnum lesions. Most of them.
This is the last question we are going to have.
Sir.
Because this is short of time, we will have to move to the relay.
Okay, sir. Most of the lesions are meningiomas or schwannomas, sir. What is the response rate for this Zap machine, sir, for meningiomas?
I mean, with schwannomas, you should get almost 100% response rate.
Regarding meningiomas, sir?
And, well, but the meningiomas, you should be almost always able to ameliorate or palliate the situation and cure the patient. Now, can some patients, because sometimes the anatomy is very complex, and you don't appreciate the extent of a tumor in one portion of it, and you may find, and I've had this happen to me, 10, 15 years later, a patient develops new tumor in a location that you didn't see, and you bring them back, you retreat them. But it's very rare that you're ever going to have to treat a case like that and come back and find that you need to do open surgery and that you theoretically failed to control the tumor you treated. Whatever you treat, you will generally almost always control. Now, is it 100%? No, nothing's 100%, but it probably is well in the high 90s, 97, 98%. And generally, if you fail, it's usually because the tumor was not a benign meningioma, it was a transitional, more malignant meningioma.
And role of this ZAP in deep-seated pediatric asymptomatic AV malformations?
Well, I have never treated a case, but I can tell you, Kita Salamanca in Madrid, he's about a third of all the patients he's treating are AVM, and many of them are pediatric. And so we have more and more people treating. I would have asked a question earlier, what is the preferred targeting mechanism for MRI with radiosurgery. There are some people who think you need to have, you can just do MRI and CT. Some people think you need CTA. Some people need projection angiography. The Zap-X today only supports volumetric data sets like MRI or CT, but sometime next year we hope to give you projection angiograms as well. So I think that you should be able to do anything you want to do with radiosurgery with the Zap-X in the brain and head and neck region. Anything.
Thank you, sir.
With this, we'll conclude the session. Thank you, Professor.
Thank you.
I now request Mr. Harshad Reddy to please come on the stage and felicitate the speakers.
I left my file there.
Starting here. I think you're the first center of the Global South. Zap.
Thank you, Professor Adler. Thank you, the chairpersons. Your video did play.
What's that?
Your video played well.
Your video played.
It did. Thank you. I was nervous for nothing, but okay. It's always good to be nervous.
Yeah. I now request Mr. Harshad Reddy to give the concluding remarks and the vote of thanks.
Shut the laptop, maybe? Yeah.
Namaste and a very good evening, ladies and gentlemen. It is an absolute honor, and it gives me immense pride to stand here amidst this august gathering of clinicians who I believe are world leaders in the field of neurosciences. During the course of the day, I have had the privilege of interacting with some of my senior colleagues who have helped me shape my career as an healthcare administrator. I also had the privilege of making new friends who I hope to develop long, cherished relationships with. One of my key takeaways from today's gathering was that I realized how important that it is to ensure that we have a multidisciplinary team approach whilst treating brain tumors. As a healthcare administrator, I would like to work with my colleagues to see how we could possibly use technology to facilitate the same. I'd also request all of you to kindly visit the Zap-X installation, to participate and promote this program so that everyone can benefit from it. I'd also finally like to thank each and every one of you for your time, for your time and your presence here today, for your contributions towards progressing the science of medicine and the wellness of humanity. I would also like to take this moment to share something that's very personal to me. I'd like to share with my colleagues at Indraprastha Apollo about how immensely proud I am to be a part of your team. Today's event and yesterday's was a resounding success. You work in an institution and have created an institution that is recognized by the nation at large. Thank you once again for everything that you do. God bless and Jai Hind. Oh, me.
I would now request Mr. P. Shivkumar, our Managing Director and Director Medical Services, Lieutenant General Bipin Puri, to please come and felicitate Mr. Harshad Reddy. Thank you, Mr. Reddy. I thank each one and every one of you for being the integral part of this ZAP conference. Until we meet again, let the spirit of innovation and collaboration guide our paths. Goodbye and take care.